Good afternoon, everybody. Ladies and gentlemen, it's lovely to see you all here. Many new faces and also some loyal supporters from the past. I'm Dr. Virginia Hobday. I'm the medical director of Jasmine, and it's been my privilege to be that since 2001. So this is our ninth biennial conference. So we've done them every 2 years for the last 18 years. And including the year of COVID when we did it on Zoom. This year it's entitled Shared Strengths, Crossing the Spectrum of Specialties. We regard palliative care as a truly multidisciplinary specialty, and it really does take a team approach to achieve excellent palliative care. Our aim then, when we started and now, is to educate both ourselves, our healthcare colleagues, and the public about what palliative care is, and to dispel myths that exist about it, not just in Cayman, but all over the world. For example, many people think that it is only for cancer patients. People also only believe that it's for the very end of life. So these are the topics that we tackle, and it is our aim to carry on doing that going forward. Palliative care is a human right, as mandated by the World Health Organization. And we believe that every person should have easy and free access to good care in what can be a very frightening time for patients, their families, and their friends. We respect each person's choices and treat them holistically with them and their family at the center of the team. We are accepted into their homes, and this is a trust we hold very dear. We aim to keep people living life to the fullest, as long as possible, supporting them and advocating for them. Our palliative care nurses are available 24 hours a day. We also have a full-time palliative care physician now. We are proud to have a beautiful facility for patient care in situations where it is needed. For example, when families need respite care, when symptom control cannot be achieved at home, and also, of course, for end-of-life care where that cannot be achieved in the home. Our villa is a serene and tranquil place, which feels as much like a home from home as possible. We hope many of you will visit it tomorrow during our open day. The facility was funded by the community, and all the care people receive is totally free. We therefore rely heavily on our amazing fundraisers and their team to provide the finance to achieve this goal. So everything from events, galas, corporate donations, legacy donations, and Flag Day, where even every single penny and dollar counts towards this aim. I'd now like to take this opportunity to thank our sponsors, without whom this conference would certainly not be possible. Baptist Miami Cancer Institute, who were our very first sponsors back in 2008. Health City, Cayman Islands, the Health Services Authority, Aon, the Wellness Center, and Doctors Hospital. Just a few housekeeping items. We will take a 30-minute break at 3 p.m. and there will be tea and coffee available. And then we have a drinks reception between 6 to 7:30. So we hope as many of you as possible will stay for that. CME and CNE certificates are available at the back of the room, so please collect them on your way out. And for those of you who are online, please be sure to fill in the form in the video description to receive your certification. I'll remind you later, but please remember to do that. Tomorrow we have an open day at Jasmine between 10 a.m. and 2 p.m. So stop by for a tour if you're in the area or you would like to see it, and there will be lots of activities going on during the course of the day, and bring your children if you'd like to too. So now it gives me great pleasure to introduce the Honourable Heather Bodden, who is the Acting Minister of Health and Wellness and Home Affairs, and she has kindly agreed to make a few remarks to start the conference off. We do thank the ministry for their support of Jasmine and recognizing its unique importance in the community. So please help me in welcoming the Honourable Heather Bodden.
Thank you, Dr. Hobday. It's wonderful to be here. Lovely audience. Just bringing you greetings from the Ministry of Health and Wellness. Good afternoon, ladies and gentlemen. It is an honor to stand before you and bring remarks on behalf of the Minister for Health and Wellness, Honorable Sabrina Turner, who sends her apologies as she could not join us today due to being off the island. However, it is important to both Minister Turner and me to support the wonderful work of Jasmine, the Cayman Islands' only dedicated hospice and palliative care provider. So I am grateful to be here today. This year's Caribbean Palliative Care Conference has brought us together to renew our commitment to one of the most humane aspects of healthcare. Our gathering together is more than just an academic exercise. It is our testament to shared dedication, learning, growth, and the relentless pursuit of compassion in our practice. I want to begin by recognizing the invaluable role that Jasmine plays in our community. As the only dedicated provider of palliative and hospice care in the Cayman Islands for over 20 years, Jasmine truly is a beacon of hope for patients, families, and individuals facing the incredible challenge of serious illness. It is here that suffering is alleviated, dignity is preserved, and the quality of life is enhanced, even in its most difficult moments. The comprehensive support offered not only to patients, but to their families as well, demonstrates what true health care should be: a partnership in care, compassion, and understanding. Ladies and gentlemen, we know that palliative care is not a mere afterthought or a service included in the healthcare framework as a part of a box-ticking exercise. Palliative care is, as the World Health Organization reminds us, as an ethical responsibility and an absolute necessity. Without it, our healthcare systems fail their most fundamental duty to relieve suffering and enhance the quality of life for patients with serious illnesses. Yet, we must recognize a global reality that for many countries, individuals, and communities abroad, palliative care is rare or not easily accessible. Patients face their final days in pain, their families burdened with uncertainty, and healthcare workers buckling under the pressure of resource constraints and adequate support. We are very blessed here in the Cayman Islands to be in the position to offer free access to the public to palliative care through Jasmine. But in reality, this should not be a privilege. It should be a universal right. It is important for us to also talk about the common misunderstandings that have become barriers to palliative care access. Too often, palliative care is seen as a service for the dying, rather than a vital component of treatment for anyone suffering from serious or life-threatening health conditions. It is not just about the end of life. Palliative care is specialized medical care. It is focused on relieving the symptoms and stress of a serious illness with the goal of improving quality of life. It's about the patient's dignity, comfort, and support, as well as living life as fully as possible, regarding of the prognosis. It is important to note, ladies and gentlemen, that palliative care is not a substitute for disease prevention and curative treatments. It is instead a vital complement to them. It is an approach that looks after all the important aspects of a person's well-being, whether it is their physical, spiritual, psychological, or social needs. And when introduced early, it can greatly improve a patient's outcomes. And it's not just the patients that are looked after through palliative care, but the people who are important to them and involved in their care are also brought into the fold. Emotional and psychological support is available to alleviate the heavy burden of illness. Excellent care teams, such as those we have here at Jasmine, are also on hand to help and guide patients and families to navigate complex treatment options or tough decisions, with the aim to not only relieve suffering, but to anticipate and prevent it before it arises. Ladies and gentlemen, palliative care, even in its most basic form, can help to relieve suffering. Life untreated, suffering, risk, or collective hope and desire to improve the quality of life for all of our people. And this is why palliative care should not only be the responsibility of a handful of dedicated, specialized professionals. No, palliative care should concern all of us at various levels of the healthcare system, from primary care providers to specialists across all disciplines. Rightly so, it should enjoy equal status alongside other critical care services because it is just as important in the overall holistic remit of care. Through this conference, Jasmine has created a conduit of information and understanding. Together, medical professionals and laypersons here today will be presented with the tools they need to fully understand palliative care as a complementary facet to any life-limiting or chronic illness treatment plan, and with the insights that are required to increase early referrals to support a better continuity of care. Palliative care concerns all of us, and for over 20 years, the Cayman Islands government and the community have supported Jasmine by fully funding their work so that no Jasmine patient ever receives a bill for services from the organization. This funding covers all of Jasmine's services from in-home and inpatient hospice care and palliative care to inpatient respite services and bereavement support, because collectively we see and acknowledge the value of palliative care and what can be achieved when partnerships are formed to support the growth, development, and reach of such an essential service. As a government, we will continue, as we have been, hand in hand with our community in support of Jasmine's work and better continuity of care for the Cayman Islands and all persons living within our shores, regardless of age, financial means, or diagnosis. Jasmine's tireless work also extends providing opportunities for learning, growth, and development, like this conference. I hope that you enjoyed the thought-provoking presentations and all the meaningful and relevant discussions around all-encompassing aspects of palliative care. Do share what you have learned from this conference with your friends and family to ensure that Jasmine's message reaches all corners of our beloved Cayman Islands. Thank you all, and may God bless you.
Thank you, Honourable Heather Bodden, for that very succinct but far-ranging explanation. I think it was really touched on every aspect of what we do in a very meaningful way, so thank you very much. So now it's my pleasure to introduce our first speaker, who is no stranger to Jasmine. He presented via Zoom on our palliative care conference during COVID, but we're delighted to have him here with us today, and he's got his lovely wife and little girl with him on this trip. So Dr. Mark Stoltenberg earned his medical degree and a master's in bioethics and health policy from Loyola University Chicago. He completed his family medicine residency at Northwestern University and then a palliative care fellowship at Harvard. He later pursued a global health fellowship at Massachusetts General Hospital and a master's in public health from the Harvard Chan School of Public Health. Currently, Dr. Stoltenberg is a faculty member at Massachusetts General Hospital Division of Palliative Care and Geriatrics, co-director of the Global Palliative Care Program, and the medical director for the Mass General Brigham Home-based Palliative Care Program. His work, both locally and internationally, focuses on innovative approaches to alleviating suffering in vulnerable populations, particularly in Latin America, Africa, and the Caribbean. He collaborates with palliative care leaders in several countries, including Belize, Colombia, Kenya, and Rwanda, contributing to ongoing education programs and mentorship. Dr. Stoltenberg is also a founding member of the Global Palliative Education Collaborative and an advisor for both the Pan American Health Organization and the International Atomic Energy Association, and currently leads a subgroup for the WHO Palliative Care Working Group. So you can understand why we're so privileged and excited to have Dr. Mark Stoltenberg with us. Please come in, and he's going to talk to us, well, he can tell you his presentation, yeah.
Thank you so much for that wonderful introduction. Thank you to Jasmine for the opportunity to come and be in the Cayman Islands and to spend this afternoon with all of you. I'm really excited to be here to speak both about where we're at in the development of palliative care globally, and then a little bit later to talk about some of the ethical issues that come up in palliative care. So thank you again for this honor. Oop, might have to turn it on. So what I hope to cover over the next 30 minutes or so is first to recognize that palliative care is a human right, as was beautifully articulated already by the Ministry of Health, and therefore a mandatory component of healthcare worldwide. Then I'll focus a little bit on highlighting the immense global need for palliative care, talk about the moral imperative, and give a little update of where we're at and where we hope the future is going. And then finally, I'll update on some of the work we're doing, or I'm partnering with the WHO to do with various other global partners to try to expand access to palliative care in the parts of the world that need it most. And a gentle invitation for anyone who wants to join us in that mission. So I think that introduction mentioned it a little bit, but just for me to share, I think the real reason that I'm here and what I really hope to speak to and share with all of you is I've had the opportunity over the past 10 years or so to partner with real heroes of palliative care all over the world. The founder of palliative care in Belize, the founder of palliative care in Jamaica, many of the founders of palliative care in East Africa, and I have learned so much from them about what palliative care is, how it can look very differently depending on what culture you're working in, what religions might be there, what language you're speaking in, and it has dramatically changed how I practice when I'm back in Boston. And so for me to just have a chance to share some of that wisdom that I've been able to get from them, I think that's actually the real reason I'm here. So I'm excited to share that with you. So I think it helps to back up a little bit. I think all of the descriptions that we've had are exactly right, and sometimes it helps to kind of go back to the origins of what exactly is palliative care and why does it exist in the first place. So this is the WHO definition. Folks have probably seen this before. I won't read it, but hopefully some of those pieces sound familiar. I think a few things I want to really pull out from this definition. So first, palliative care is all about quality of life. We sometimes think about quality of life and suffering as two sides to the same coin. So we are always seeking to minimize suffering and maximize quality of life for patients and their families. And I think the last piece that's important is just as was stated, this is not just for end-of-life patients, it's not just for terminal patients, it's for any patient with serious illness. We know lots of patients suffer when they're sick. Not all of them go on and die. Palliative care seeks to care about that suffering while we're still treating their diseases and trying to reverse and cure when we can, which we'll speak about a little bit more. So when you hear palliative care, I would say it's maximizing quality of life and minimizing suffering for any patient with serious illness, period. That sort of helps us bring it back home. I think another way, and I think the most important part of this definition, is just naming it as a response to suffering. So some folks have maybe seen this painting before. The title of the painting is The Doctor. So this is a story from back in the late 1800s in the UK. And it was a pediatric patient. It was a young boy who was dying. The doctor recognized that the patient was dying and knew he did not have anything to treat or to reverse this process. So he recognized the patient was dying. Despite that, he continued to come almost on a daily basis. He managed the boy's symptoms to make sure that he wasn't suffering. He communicated with the patients to help prepare them for what might be coming. He provided support for them. And then ultimately, weeks later, the boy did die. And the father was so impacted by this experience and the way that this doctor came and provided compassionate presence, listening, partaking in whatever rituals the family needed to do to prepare for this horrible, horrible thing to happen, that then the father said, I need to remember this, and the world needs to remember what it means to be a clinician. And so he's actually the one that paid for a painter to make this painting, so that they would always remember this is what it means to provide compassionate presence. So palliative care is not new. It has been around as long as humans have been caring for each other. But there have been unique changes that have occurred in our healthcare system over the last 100 years, where some would say we've forgotten some of those parts. And what palliative care does is it brings it back. It says, of course, let's cure and fix and prevent your suffering whenever we can. I love science. I love CT scans. I love antibiotics. I love safe surgeries. But now that we have those things, we've sometimes convinced ourselves that's our only job now. And we have forgot what it means to care when we cannot cure. We forgot what it means to be with when we know we can't reverse the thing that's in front of us. That's what palliative care tries to bring back. So I think another way to think about this, who's heard of Cicely Saunders before? Guessing a number, yeah, certainly our UK colleagues have heard. So the founder of modern hospice. So Cicely Saunders is from the UK, was originally a nurse, but then after her experience in nursing, which I'll share in a moment, went back to school and became a social worker. After that, went back to school and became a physician. So she was an interdisciplinary team all in herself. And as the story goes, she was initially, when she was a nurse, before she had done that further training, she was working on an oncology ward. And at that time, when the oncologist felt there was no more chemotherapy or direct treatments that they could provide, the doctors would say, there is no more role for me because I cannot cure them. They would move those patients to a corner of the ward, and they would leave the nurses to manage them as best they could. Cicely Saunders said, but she was deeply Christian herself, so it came from some of her own values. I've seen these values play out with lots of other faiths too, so it's not unique to Christian, but she was very Christian herself. And she said, these patients still have dignity, and there is still suffering we can treat. This is unethical, and there is still more work to be done. So what Cicely Saunders did, after this line was drawn in the sand by the oncologist, she said there is still evidence-based ways we can maximize the quality of life and minimize the suffering for these patients that at the time were in their final days to weeks of life. And that is where the hospice movement came from. So modern hospice came out of this science of caring for those at the end of life to minimize their suffering, that Cicely Saunders was really the founder. Now what happened over time is folks started saying, wait, communicating really effectively with patients and their families, optimizing symptom management, making sure that we're thinking about spiritual and psychosocial suffering, not just their physical suffering. Why are we waiting for this red line to do all these wonderful things? We need to be doing it earlier. That's the birth of palliative care and where palliative care came from. It said from the point of diagnosis of any serious illness, we should be caring about both the disease and the suffering, both the disease and the quality of life, and we should be doing it throughout their entire disease course. That is, I think, a helpful frame that whether you're in Rwanda or Cayman Islands or Jamaica or Boston, that will serve you well of understanding what is palliative care and how can it help. So as we discussed, really important piece, so palliative care looks at all the ways in which folks can suffer. So the physical, but also the psychosocial, the spiritual, in many parts of the world where I work, the economic. There's an immense economic suffering and burden that can come with serious illness. Palliative care cares about that too. And also, we're not just talking about the patient, but we're talking about the family, and sometimes we're even talking about the extended family in the community, because patients don't suffer alone. They suffer as a group, and they suffer in their networks. The other really important part of why I like this graphic is the first step of high-quality palliative care is always the very best traditional medical care we can provide. If we can prevent the suffering, always better than managing the suffering. If we can cure the suffering, great. So there's never this discussion, are they ready for palliative? Is it time for palliative? That's like asking, is it time to think about radiology? What? We think about radiology the whole time. Is it time to think about antibiotics, or are they not there yet? That doesn't make any sense. If there's an infection, we treat it. That's how we should be thinking about palliative care. It is another specialty that helps with a component of the way patients suffer and that we can maximize their quality of life from the point of diagnosis. So it is always meant to be fully integrated with traditional care. There is no competition. They are meant to go together. So now I want to update a little bit of how things have changed over the last 10 or 20 years. So that's great. This is sort of the origins, the theoretical origins of where palliative care came from. Some folks would then look at that and say, well, that sounds nice, but we have limited resources here in our Ministry of Health in country X or country Y. This sounds like something fancy we'll do eventually, but we need to focus on some of the other fundamentals first. So that was an argument that was heard 20, 30 years ago. So the other thing that has substantially changed is the evidence base for palliative care. So I'll highlight two pieces of that. So first of all, we now know that if we integrate palliative care from the point of diagnosis, it actually improves patient outcomes. So we were just discussing at our table here, one of the first really important trials, so it was a randomized controlled trial of patients with stage 4 lung cancer. The first group got standard of care. Most of them got palliative care eventually, but only when the oncologist felt it would be helpful or necessary. Usually it was in the last month or two of life. The treatment group had to get palliative care from the day they got diagnosed. So from diagnosis, all of them were stage 4. They would see a palliative care specialist at least twice a month, and if they were admitted in the hospital, at least twice a week. That was it. That was the only difference in these two groups. And ultimately in the intervention group, their rates of depression were substantially lower, their anxiety rates were substantially lower, their quality of life was higher, and they actually lived 2 months longer. That dramatically changed how the medical field thought about palliative care. So now on top of that, there have been a growing body of evidence, and not just in the US, in Europe and also parts of Africa, some in Latin America, that if you fully integrate palliative care across a healthcare system, not only does it improve outcomes, it actually decreases overall healthcare costs for the system. So those are two huge landmark outcomes for the evidence base for palliative care. The last sort of piece of the puzzle that was really important, so there was a really important paper that came out in 2017. It was the Lancet Commission on Pain and Palliative Care that one of my mentors directly worked on, and a lot of my colleagues were also a part of. And this was a really important paper. They did two things. They first worked with epidemiologists to evaluate the overall suffering burden of illness in the entire world. No small task. It took them many years to try to do that. They thought about every disease, how much suffering would occur, what is the typical trajectory, and then actually give a number to it. The second part, this was the part that I found the most interesting, is they then took that amount of suffering and they partnered with economists to say, if we were to provide basic palliative care, not advanced, high-tech, state-of-the-art, just basic palliative care, how much would it cost to cover for an entire country? And they specifically looked at 3 countries, a low-income country, a low-middle-income country, and a middle-income country. And you can see them, so it was Rwanda, Vietnam, and Mexico. And the part that you can see highlighted in the yellow, so for Rwanda, a low-income country, for that first year of intervening and providing basic palliative care across the system, around 3% of healthcare expenditures. Not a massive amount, but a pretty significant amount. Looking at Vietnam and Mexico, we're talking half of 1%. That's for 1 year's investment. Over the next 10 years, it'll actually save you money, and we know it'll also improve outcomes, and the patients will be suffering substantially less. So with this piece, it became unavoidable for ministries of health all over the world. This is no longer optional. It was already declared a human right. Now we have the evidence to back it up that it's feasible, affordable, and we know it improves outcomes and it'll decrease costs over time. When I meet with ministers of health across the Caribbean and also in Latin America, it's no longer if we're going to do this, it's a matter of how, because they've now all accepted this is just something that needs to happen. And I applaud the Cayman Islands, and largely because of everything Jasmine's doing, you are far ahead of most of the other folks in the region, and there's so many patients in various parts of the Caribbean that still need this. So I feel like Jasmine can be a wonderful example for them so that we can continue to increase access. And the last piece I'll say on sort of this data point, because I think it's important to hear that data, but sometimes what does this actually look like for patients? So as I shared, I was in East Africa for a while. I was teaching palliative care in Rwanda and Kenya for 3 months each, so a total of 6 months. 2 of the hospitals that I worked at, we had patients, often pediatric patients, coming in with bone cancers that had not had a single milligram of morphine in months because it wasn't there, not accessible. The clinicians didn't know to prescribe it. They would finally get to the referral hospital, and you would see these kids, and the moms would say they haven't smiled in 5 months. They would show up to the hospital. We'd give them 5 milligrams, 10 milligrams. This costs pennies to be able to give it to them, and you would see smiles on their face. There is no value for the smile on a child's face that has not smiled in 6 months. Those are none of my patients. Those are actually my 2 oldest kids. But a smile on a kid's face is the same and is truly universal across cultures. There is no reason kids should not be smiling because they don't have access to something that costs pennies. So it's to take this data and make it human for us. This is just deeply unacceptable, and we all need to be committed. We're not going to give up until every child and every human has access to these basic services. So as we discussed, because of this, palliative care has now been declared as a human right. So it is not optional anymore. And the WHA, which are the ones that give the guidance for the WHO of what to do, have said it is an ethical responsibility of every healthcare system worldwide. So that's the data. That's the background. So we have the evidence. The WHO has said this is a mandate. We recognize that this can be done. It's affordable to implement it. Where are things at? This is one way to measure the current access to palliative care globally by looking at the total oral morphine equivalents per palliative care patient. So to quickly give you an idea, this is how many oral morphine equivalents a patient will have throughout their entire serious illness course. So for those of you that have worked with cancer patients, can you imagine managing a patient's cancer pain with a total of 53 milligrams of morphine, not daily, total for their entire year? You can't. What does that mean? It means the vast majority don't get any. And a few get a little bit. And that is still what the status is for the majority of palliative care patients in low and middle income countries. There are examples around the world where there has been progress, but there is still an immense need, and we're nowhere near where we need to be. So the partial good news, and that's where I hope to move us into some of the hopeful things that we're trying to work on of how to close this gap, is the development of palliative care specifically in the Latin America and the Caribbean. It's incredibly heterogeneous. So there are places like Costa Rica that have fully integrated it across their entire healthcare system in an affordable way, which is incredible. They're one of the best examples in Latin America. Uruguay is close behind them. Other places like Chile that have done it for cancer patients, and now they're finally rolling it out to non-cancer patients. But there are also other parts of Latin America and the Caribbean where access is still abysmal and almost none. So there are places that have shown us how to do it, but there are still many corners of this half of the world, not to speak of the whole other half of the world, where we still have a long ways to go. So I think one way that I would describe where we're at now is that we are in a new phase of development for palliative care. So we needed Cicely Saunders to inspire us, to show us what it means to respond to suffering, and then we needed other palliative care specialists to show us this needs to be applied from the point of diagnosis and across all patients, not just in their final days or weeks of life. And then after that, we had to figure out, so what is palliative care? How do we manage suffering? How do we measure suffering? And not to say there's not still a role for continuing to work on that and study it a seventh or an eighth time. I'm glad academies exist. I'm glad folks at my medical school are doing that. However, we have pretty good systems now. We have a pretty good idea of how to do this. So the way I would describe it is we needed to build the boat first, and I am grateful we built it. How big is this end of the ship? How long do we measure this? What sorts of medications do we use? What are the likely side effects? How do we think about social suffering? Really, really important. We should continue to think about that, and it's time to sail. It's time to say we have systems that work well enough. We see basic palliative care, smiles on kids' faces. We need to think about scale and implementation. How do we take these systems that work, make them affordable, and spread it to every last corner of the world? That's where I think the real need is right now, and that's where our attention needs to be. So I think as we think about that, so I've had the opportunity to work as a consultant for the Pan American Health Organization for a long time, and now I'm in the working group for the WHO. So I just briefly want to share with you what are some of the key conclusions from those of us that are committed to it's time to sail, and we need to start closing this gap. So I think the first of two things that I'll highlight for us today. First of all, palliative care at the specialty level continues to be rare, even in the US, Canada, and Europe. We, of course, need to keep training specialists, and that's an important part of the solution, but that is not the solution. There are far too many patients suffering that we will ever answer this by just training specialists. We need to integrate basic palliative care and intermediate palliative care where it's necessary across the entire healthcare system. Every primary care doctor needs to understand basic pain management for cancer patients or for patients with CHF, COPD, advanced illnesses where they might need to think about using opioids intermittently. We need every patient across the healthcare system to understand what social suffering is and why it matters. We need every patient to understand spiritual suffering is important, and just as important as figuring out what their white count was yesterday, you need to be thinking about how they're suffering spiritually and how we're going to meet those resources for them across every regional hospital, every clinic in the entire healthcare system. And then we need a way that patients can move from that primary system up to the intermediate and even to the specialist level when they have more advanced or complex suffering, and then they can move back and go back to their communities and be with their families and be closer to home. So that's lesson one. I was honored to participate as the coordinator, so we created a guidance document for how to integrate palliative care into primary care. So we have the tools and we have the suggestions of how a healthcare system can do this. It's something we need all healthcare systems to be thinking about. How do we integrate the basics of palliative care across the whole system? So here were some of the key recommendations from that document that we wrote. So we know primary care is the backbone of a fully integrated universal health system, and we know in many places that don't have developed primary care systems yet, the way to do it is you actually just build them at the same time. If we can enhance palliative care, it makes primary care better. If we can make primary care better, it's going to make palliative care better. So if we can just train those and build them up at the same time, If we want to build great sort of accessibility for opioids to treat cancer pain, we can also at the same time think about other essential meds for basic primary care. So it's something that is meant to be done together. And then ultimately, as we said, the ability to get specialist care when we need it, but then for patients to get back home or closer to their communities when that's where they want to be, either in managing their serious illness that go on and get cured, or for those that are nearing the end of life so that they can be in the setting that they prefer to be in for their end of life experiences. The second piece, and I think the piece that I'm most focused on and I'm the most excited about, is to really close this gap quickly, we need global collaboration via coordinated networks. Now, some of this is we continue to have an immense amount of resources, money, but also research infrastructure, other things in part of the global north. So in the US, in Europe, many here in the Cayman Islands as well. So there are resources that currently are not equitably distributed around the world. So we need to try to share those resources so that we can try to help the parts of the world that need the most, where this gap is the widest. But the other piece, the most innovative palliative care programs I have ever encountered, not a single one's in the US. It's in Costa Rica, it's in Jamaica, it's in Belize. There are incredibly innovative, creative, culturally congruent palliative care programs within low and middle income countries, and where we are not often enough offering a way that they can share those with each other. So there's a wonderful solution in Costa Rica that's going to work great in Bolivia. They don't need to look to Boston how to do this. We just need to find a way that they can connect with each other. So yes, there is an immense amount of need, but there's also immense strengths spread out all over the world, including the global south. We need to build programs where some of the tangible resources from the north can be supported and shared, and the expertise and the innovation is not something that's uniquely coming from the north. It comes from all over the world, and we need to help folks so they can partner together. So that's where we're really trying to work and what we're trying to build now. So this was the WHO working group. It had been virtual for a few years, but now has really launched in earnest. Last year, this was in Madrid, and we have our next meeting in about 2 or 3 weeks in Memphis, Tennessee. So this group is now coming together to think through how can we continue to move some of these things forward. So the one piece, so I'm leading one of the subgroups. So there's a lot of different work that the group is doing, but I'm going to focus on the one piece that I'm leading and that directly connects to thinking about building these collaborative networks. So one piece of this, so a separate collaborating center that's partnering with the WHO, it's called the Atlantis Global Observatory. They're based in Spain. They're trying to measure the current developmental status of palliative care in every country in the entire world. So they partnered together and worked to identify the 7 core areas for palliative care, and then they picked indicators in each of those, and they're doing a big process to be able to measure where exactly every country is. Where I have then reached out to partner with them and our partners at Harvard to say, great, we will then have a set point where folks are at, but what are we doing next? How are we going to help them close the gap? How are we going to help them after they've identified their strengths, but also their areas of need, so they can actually improve, grow, and start to close this gap for the patients that need access to palliative care. And so this is where this idea of creating regional networks. So why are we doing it? There is just too much work. There is so much scaling that needs to occur. Do we really need 30 different groups to create a new undergraduate curriculum in palliative care? There are 3 or 4 excellent ones out there that already exist in the Caribbean or Latin America. Why don't we just take the best 2 and just give it to everybody? If we know there's been 3 or 4 places that have created an inpatient palliative care unit like Jasmine, why does somebody in Trinidad or somebody in Jamaica have to build it from scratch? Can't they just borrow the evaluation things, the processes, the ways that it's been set up in other places, and we just share it so everybody can grow more quickly? That is where these networks are aiming to do, that we can take the best solutions that have already been created and just share them as widely as possible so we can close this gap as quickly as possible. So just briefly, so the Atlantis indicators, you might not be able to see them, but this is all online, freely available. Those are the indicators that they're using to measure the developmental level in every country. And then we have come up with collaborative items, so tasks that could specifically be done via a small group of collaborators, 3 folks that identify that area as a strength, 3 groups or partners that identify that it's an area they have a need that they want to work on. So they want to build an undergraduate curriculum. They want to create an inpatient consult service. They want to try to write a national law for palliative care. There are countries that have done that. Partner them with 3 countries that are trying to work on it, share the best practices, and then over 6 to 12 months, they will work on that collaborative task to try to close the gap. So that is currently where we're working. I will pause there for a moment and name, when we think about how important palliative care is, and we also think about the complexities of working across governments, working across cultures to close this gap, what some folks sometimes say is this can feel like an ocean of need. It just looks absolutely enormous. How could any individual one of us really make a difference, and it can feel overwhelming and make us ultimately say, I'm just gonna focus on the corner of the world I have. I think what I wanna highlight is absolutely, I hope all of you hear this and say, that's unacceptable, and I wanna try to contribute in that. And I will tell you, if I was here just based on moral outrage, I think I would have given up 5 or 10 years ago. Being angry about the injustice can hold you for a while, but the reason I still do the work is how much fun it is. The opportunity to partner with our international colleagues in other parts of the world, learn from these creative ways in which they've learned to care for their own communities, that is the reason I'm still in it, and that is my invitation to you. So yes, see that picture of a kid smiling and say, I don't want a kid to not be smiling, and I promise you, if we do get you in the door, it's also incredibly joyful, and you're gonna learn a lot. So here's a couple of examples. So my colleagues in Chile, the way our hospice system works in the US, I don't know if folks have it, it's pretty broken and it's getting worse. I learned what physical therapy and what function really looks like at the end of life because of my time in Chile. I never learned it in Harvard, in Boston, in Chicago. I never learned it until I went to Chile. The definition of resiliency, I think Dr. Dingle Spence has maybe been here before. Many of you know her, the founder of Palliative Care in Jamaica. I never understood what resiliency was until I spent time with Dr. Dingle Spence in Jamaica. She taught me what resiliency is. And then finally, you can see the folks on the far right. That's part of the nonprofit organization that provides palliative care in Belize. It's a longer story, but ultimately they taught me what spirituality supports. So they have one doctor that on her free time would sometimes see patients and try to manage symptoms. This large community of volunteers that would go and pray with patients. If you ask what palliative care was 10 years ago in Belize, they would say, oh, it's the wonderful group that comes and prays with me. We would sometimes go with the doctor and they'd say, leave the morphine in the corner. Can we start praying now? Because that's what was important to those patients. And I learned what spiritual care and what community-based spiritual care is because of my colleagues in Belize. The last example I'll share, so a colleague who's an ICU doctor in Brazil. These are our colleagues. There's Dr. Spence in the middle, and then an ICU doctor from Brazil, and then our colleague from Chile. In the midst of COVID, our colleague in Brazil had learned a lot of the communication techniques we use in Boston, but found they just weren't working in the midst of all the mistrust and challenges that he was facing in the ICU in the middle of COVID in Brazil. We came together and have now been partnering for the past 2 or 3 years to think about a different way to teach communication that we'll talk about a little bit at the training that we're gonna do with Jasmine on Sunday. It has fundamentally changed how I think about communication. So how I teach, how I actually practice has been much more seated in South America than anything I learned in my years of training in the US. So another example, yes, join this movement because you see that this needs to be better, but also I think you're gonna stay because you're just gonna learn so much and it's so much fun to be able to partner with people like this. So finally, the words that I'll end on. So the world desperately needs more palliative care, and the opportunity to partner with palliative care leaders is both incredibly rewarding and also professionally transformative. And where we're hoping to seek is to enable more and more people that want to participate in this, that we can create more seeds of these partnerships from one country to one country, eventually one institution to one institution. And if anybody here is interested, we're going to be launching the Caribbean Palliative Care Network. We started it back in February, but we're now revamping it, and we're going to start it in earnest in about a month. So anyone at all who's interested, just reach out. I will throw your email on the list. The more the merrier. We want as many people as possible participating in this. So with that, I'm happy to take questions. Thank you again for the opportunity to speak.
Thank you, Dr. Stoltenberg. That was really amazing, and I love to see palliative care as a global thing. I always say we're like magpies. We take from each other. You don't need to reinvent the wheel, and that's the beauty of palliative care. So have we got any questions? There is someone going around with Steph there has a microphone. Any questions for Dr. Stoltenberg?
Thank you very much for that presentation, Dr. Stoltenberg. You mentioned congruence with the global collaboration. Is that is that one of the things that the Global Observatory is doing to make sure whatever you come up with is culturally sensitive, countries that's involved?
So the Atlantis group is just measuring the indicators for each country. So they're reaching out to anyone who's participating in palliative care to submit data to them so that they can collate it. But then the actual partnering together is the regional networks that our subgroup is leading for the WHO. And that ultimately is anyone from any of the countries in the regions where we are able to participate. And then we'll have initial Zoom calls to explain what it's for. And folks will fill out surveys identifying where they think their strengths are and where their needs are. And then we're going to match up smaller groups so that they can work together on one of those 21 collaborative tasks. And then we'll give folks every 6 to 12 months an opportunity to say, I think I'm good, or, oh, that was really helpful, now I want to do a different area. And the dream is that over time, people will sometimes go there for the things they need, but then are going to come back and come with their resources and strengths so that everybody's going to be exchanging the best ideas. And if anyone's interested, you can just send me an email.
Is there a deadline for that, or is that ongoing?
It is ongoing. It's
Okay.
the one key piece about it. So Carrie Palka exists, as folks might know, for the Caribbean. It's the Palliative Care Association. There are other palliative care associations. We are very intentionally making these collaborative networks open access. So they, by design, anyone can join at any time.
Just talk. Thank you very much. It was a really interesting and great talk. And I think everything you said about global infrastructure needs and communication. And as you were presenting, one of the things that caught my eye is how many places in the world are deficient in pain medication and what a worldwide problem that is. And clearly there's a lot of drugs out there. I mean, you go back to poppy growing and where it all goes, and it seems to me there's billions of dollars in illegal drugs out there, but yet we have a problem with medically available pain meds. And so I'm wondering if a global organization like the ones you work for are in any way associated, say, with law enforcement or whatever, to try to get some of that opioid traffic more into pain meds.
Yeah. So it's a great question and a larger question, so I'll try to answer part of it, and the rest might have to be over cocktail hour tonight because it's a big issue. First of all, I think, yes, so the WHO, so the INCB is the International Narcotics Control Board, so any country that's importing opioids for medical use, they are the ones that regulate how much they can get, and they work very closely with law enforcement to keep it safe. And to be clear, we want to increase access to opioids, but legally for the patients that need it, and also specifically for palliative care patients. So opioids for chronic pain is a very different topic. I am not an expert, but I at least have lived in the US for a while. Pushing it for chronic pain is a very different advocacy effort, much more complicated. I think for a while in the US we were using it a lot. Didn't go great. What we are advocating for is specifically for palliative care patients. So for palliative care patients, access needs to be increased, and we need to partner with the INCB and local law enforcement to make sure it's accessible and also safe, and it's not going to be abused. Okay, thank you very much.
Okay, our next presenter is Dr. Karina Davis-Irons. She is a highly accomplished consultant anaesthetist at the Cayman Islands Health Services Authority. With a rich background in hospital and healthcare, she goes beyond anesthesiology, also excelling in intensive care and pain management. Driven by patient-centered care, she blends clinical expertise with compassion and unwavering ethical principles. Her understanding of medical law and ethics equips her to navigate complex healthcare regulations while upholding moral perspectives. And her holistic approach to healthcare embodies her dedication to both medical and ethical excellence, showcasing her as a guiding light in the field and significantly contributing to the healthcare enhancement in the Cayman Islands. And she's going to discuss ethical challenges before and after capacity loss. So please help me in welcoming Dr. Davis-Irons.
Good afternoon, everyone. Thanks to the Jasmine team for inviting me to do this presentation. It is indeed a pleasure to be here in this capacity, and I look forward to having a discussion with the team about before and after patients lose capacity and the ethical challenges that are associated. So the objectives here, my objectives will be threefold. Firstly, to understand the evolution of care when a patient loses capacity, emphasizing the importance of comfort-focused care as we transition from clinical care in patients who are terminally ill and require such transition to palliative care, to emphasize clear communication between healthcare teams and families. Secondly, examine the ethical, legal, and clinical implications of capacity loss, while looking more specifically at the challenges that are associated with decision-making. And finally, to highlight the importance of early advanced care planning, emphasizing the need for early conversations on care preferences for patients. Now, as during my introduction, you would have learned that I'm an anesthetist/intensivist, and I have a keen interest in medical ethics as well. So this dual role gives me the advantage of looking at things from the perspective of a clinical care, looking at patients from a clinical care perspective, and also looking at the aspect of clinical science versus the humanistic care for patients. And what this does is give us the ability to approach patients from a humanistic standpoint where their care, which is what they desire, but also deserve. So as we go through this presentation, you'll see the transition, how we combine both together. So we're going to start by looking at capacity and what capacity means. What does capacity mean in the clinical sense? So capacity is the ability of patients to make informed decisions about their own care, and this involves them being able to understand the information that we as healthcare providers give to them. They should be able to retain the information. They should be able to weigh the pros and cons of the information we provide to them. And of course, they should have the ability to effectively communicate this decision. Now I'm going to start by just looking at this case. Some of you may be familiar with this case. It's a case of Terry Schiavo. This young lady, in 1990, she experienced a cardiac arrest at home. Unfortunately, she had significant hypoxic brain injury, so there was decreased oxygen to her brain for a period of time, and she ended up being in a persistent vegetative state. After she went into a persistent vegetative state, despite pleas by her husband, who was in fact her legal guardian, he explained that she wouldn't have wanted her life to be the way it was, highly dependent on tube feeding. However, despite his pleas, her parents fought to keep her alive. This case highlighted the importance of advance directives, and it also highlighted the battles, the ethical and legal battles, as well as emotional conflicts that occur when patients do not have an advance directive. So we're going to use this case and look at a hypothetical case, right? So that was a landmark case. It took 15 years to resolve. In March 2005, her tube was removed and subsequently she passed. But it took 15 years of turmoil, emotional conflicts, legal conflicts, ethical conflicts. So I'm going to use a hypothetical case, and this case is, we're going to call her Mrs. E.B. So this lady is a 69-year-old retired school teacher. She was diagnosed with advanced Alzheimer's disease 2 years ago. She lived in the Cayman Islands with her daughter Patricia, who was her primary caregiver. Before her diagnosis, she was a highly independent woman who enjoyed spending time with her family and friends, as most of us like to do. She was aware of the potential cognitive decline associated with her diagnosis. As she progressed, she had to consider what her options are if and when she loses capacity to make medical decisions. So as her cognitive decline set in, she had to have something in place who would make decisions on her behalf. So she could, one, leave all her decisions to Patricia without any specific directions or guidance, or she could engage in advanced planning. The advantage of her using advanced planning would be that she would be able to set clear boundaries. So not only would she be able to dictate her wishes at the end of life or approaching the end of life once she loses cognitive abilities or she has her cognitive impairment worsens, but she was also able to set boundaries. So in terms of setting boundaries, she could set boundaries in terms of her medical care, what she would not like to accept. And that is very important. So what is advanced care planning? So this is a process of discussing and documenting a person's preferences for future medical care, particularly in situations where they may no longer be able to make decisions for themselves. So otherwise known as capacity. So they've lost their capacity to make decisions on their own. It involves conversations between individuals, their families, and healthcare providers. This conversation will clarify goals, values, and preferences at the end of life. There are some key components to this process, which may include completion of advanced directives, which are legal documents that outline specific treatment preferences or appoint a healthcare proxy to make the decisions on behalf of the individual. So, as important as this advanced care planning is, the uptake is low globally, right? So as you can see from the figures there, from the UK, 10.5%, US, 37%, which is the max. And I've seen as low as 1.5% in areas such as in Europe. Now, I don't have any local data or any for the Caribbean, but what I'll do with the next slide is to bring some awareness to what exists or what the authority that exists here in the Cayman Islands. So we have the Healthcare Decisions Act, and as you can see there, the Act defines Advanced Healthcare Directive as a document made by a person expressing the person's healthcare wishes in the event that that person becomes mentally incompetent, including, for example, that that person wishes to be denied life-sustaining measures if that person becomes terminally ill or does not wish to undergo another stated type of health care. So bear in mind, wishes to be denied life-sustaining measures, that is key here. It defines proxy as a person appointed by a directive maker to make decisions about that directive maker's health care. Now, I won't go into the details of this act nor the contents of the form, but both the act and the form is available on several websites, including Jasmine's website as well. So you can feel free to take a look after this presentation to peruse it. But the form itself is pretty straightforward. It's like several pages, but it is pretty straightforward. And I do encourage everyone, if you've never seen it, to take a look at it. So going back to Mrs. E.B., she was privy to this information, she knew her options, and she decided to engage in advanced care planning. And she decided to do this at the right time, way before her cognitive abilities deteriorated. In this directive, she clearly stated that once she was no longer able to recognize her family, she would want us to, as healthcare practitioners, focus on comfort care, otherwise known as comfort-focused care, which is where palliative care comes in. She wishes not to have any life-sustaining treatment in the event her cognitive function declines significantly. She also designated Patricia, her daughter, as her healthcare proxy. She expressed clearly to her doctor and family that her biggest fear was being kept alive in a state where she no longer had meaningful interactions. And I guess most of us can relate to that. She wanted her final days to be peaceful, which we all want, with palliative care aimed at maximizing her comfort. So she's able to express this way ahead of time. And she did the right thing by having these things documented. Unfortunately, over the next 2 years, her condition worsened. She experienced frequent confusion, began losing ability to even recognize Patricia, her own daughter. She later developed pneumonia, which led to sepsis, and unfortunately, without aggressive interventions such as life-sustaining measures, such as mechanical ventilation, cardiovascular support, it's unlikely that she would survive. And this was communicated to Patricia. Now, the management team, the medical management team, being aware of her advance directive, offered her only comfort-focused care and administered antibiotics and oxygen to keep her comfortable. But no invasive measures were implemented, such as mechanical ventilation. Understandably, this can be difficult for the medical team as well, because for this particular case, let's say the medical team recognized that evidence-based medicine would support them giving her mechanical ventilation, cardiovascular support, and she would have a reasonable chance of recovery. However, given her advance directive, it was imperative that they honored her wishes and respected her autonomy. Now, to twist the story a bit, her son, Daniel, who lives overseas, now came to visit. He's now quite upset, understandably so. He wasn't a part of the discussions before. He's upset that his mother is in such a frail state, and he disagreed with the decision to avoid more aggressive treatments. He felt that mechanical ventilation and intensive care would help his mother recover. He pleaded with his sister to authorize aggressive treatment, believing that it was in fact in her best interest. I'm sure many of you healthcare workers in here can relate to this scenario. One family member has information on the clear wishes of the patient, and then another family member comes and says, no, that's not what she would have wanted. And they are of the impression that the healthcare team and the other family member are giving up on the patient, and you should do everything to save the patient. So he was quite upset. Patricia now, being the healthcare proxy, she's now torn. She's now torn emotionally. She has to honor her mother's wishes, and at the same time, she has to process her brother's emotional plea. Do everything possible. We hear this all the time. The medical team may also experience some conflict. Again, as I said before, based on evidence-based medicine, for this particular case, she probably could have had a reasonable chance of survival. But they recognized that her advance directive was legally binding and in alignment with ethical principles, respected her autonomy. So, because of the conflicts that existed, particularly with the family members, the ethics committee was invited into the conversation and management of this patient. So they convened and acted as a mediation group. The committee reviewed her advance directive, which explicitly stated her desire for comfort care and absolutely no life-sustaining treatment. They emphasized the importance of respecting her autonomy despite the emotional difficulty the family was experiencing. They offered support to Patricia, her being the healthcare proxy, and also offered support and gave support to Daniel, the son, who was in his grieving process and not understanding exactly what was happening. So I'm just gonna go a little bit more into the information behind this case, so just bear that case in mind and the rest of the discussion will relate somewhat. So before losing capacity, what do? So ideally, as mentioned before, we start early. Same goes for advanced directive and advanced planning. We start early. So us as healthcare physicians or healthcare workers, we engage patients in open communication. We have to remember this is a shared decision process, and we are expected to provide patients with the relevant information, allow them to process the information, allow them to weigh their pros and cons, and make an informed decision. The decision is not going to take 5 minutes, 10 minutes, a day. Sometimes it takes months. So the earlier it is done, the better. The information aspect, very important. The patients get a chance to express their wishes not only with respect to the end of life, but also with respect to pain management during palliative care, the side effects of these drugs, etc. Is it something that I want? So they get to engage in those discussions as well as able to express their preferences where spiritual and emotional support is concerned. Now, there are ethical challenges that exist, not just after losing capacity, but even before losing capacity. We have to remember that this open conversation that we're having with the patients, where we're sharing the information and extracting their needs and their wishes, it's somewhat of an informed consent process as well. Sometimes I like to call it informed refusal if they're refusing particular care. When they are, during this process, there are 3 things that are absolutely necessary. 1, we know the patient must have capacity at the time. It must also be voluntary. And there are times when there exists external influence, usually from relatives, sometimes even from other physicians or other healthcare workers, that influence the patient's decisions in terms of them planning for their end-of-life care. So we have to be very careful about that and ensure that their decision is voluntary at the end of the day. Now, the information should be provided to them in a way in which they understand it clearly, bearing in mind that we have patients with different intellectual abilities, so we have to be able to translate that information effectively. They should be able to weigh the pros and the cons and make an informed decision, whether it be consenting to a treatment or refusing a treatment. Bearing in mind that some patients will still struggle to make these such complex decisions, and it will be affected by their very own emotional struggles and barriers. Am I giving up? Should I just say, don't do everything for me at the end of life? So they have their very own emotional struggles. In terms of the communication, yes, we've established that the communication needs to be adequate and it needs to be effective. How about the communication coming from the healthcare workers' perspective? Oftentimes, healthcare workers are hesitant to start this conversation. Not deliberately, but the emotional aspect that comes with this type of conversation. End-of-life conversation is not the easiest conversation to have. So as healthcare workers, we have to be able to train to have these conversations and empathize with patients and be able to bring that information to them. So the point is try not to avoid it because it is uncomfortable. Over time, it gets a little bit easier. We also have to consider cultural and religious beliefs of our patients and families. And particularly here in the Cayman Islands, where we're multicultural, we have to recognize that there are even some cultures that do not want to engage in such conversations. What we do, we approach these conversations in a sensitive way, we empathize with them, and at the same time support what their beliefs are while still trying to educate them on their options. As mentioned before, there may be some resistance from family members, and sometimes patients struggle because you're saying to them, let us start this conversation. Some may interpret it that they're going to die tomorrow or next week or next month. We have to be very careful about that. There can be great difficulty in predicting when a patient may lose capacity. Again, the earlier we start the conversation, the better, and we have to sensitize patients to that as well. I'm not saying you're about to die, but it is expected that at some point you may lose capacity. Now is the best time to have this conversation. And of course, there is the varying legal frameworks that exist across different regions. After losing capacity now, so that's all before losing capacity. After losing capacity, we have to recognize again that there is a shift in the care for the patient, not only in the care of the patient, but the decision making. So proxy or surrogate making decision becomes more prominent, becomes prominent at that time. Healthcare workers, again, choose to act in the patient's best interest. And if an advance directive exists, then they act on the advance directive. Otherwise, they would act in the patient's best interest. Bearing in mind, again, there will be maybe some potential family conflicts after the patient loses capacity, and we address ethical dilemmas as they come with the appropriate committees. Now, how does it impact the actual care? We have to sensitize family members and patients, well, the patients before they lose capacity. After they lose capacity, we have to sensitize family members what comfort care is about, what comfort-focused care is about, and the role of hospice, the role of palliative care medicine, because there will be a transition. So what they're accustomed to seeing will change. It's not a matter of giving up on the patient, but in fact preserving their dignity and ensuring that they're comfortable. Of course, there may be some emotional and psychological impact, which we have to address as well. Ethical challenges that come after the patient loses capacity. Even if an advance directive exists, some family members or even healthcare workers may question the validity of this advance directive. So that is something to bear in mind. Again, conflicts as seen with Daniel and his sister, and we should not underestimate the challenges that healthcare workers have with some of these advance directives as well. If a patient does not have if a patient has not designated a healthcare proxy or completed an advance directive, the healthcare providers must turn to surrogate decision makers to decide on the patient's behalf, and this is known as a substituted judgment. Surrogates are then tasked with either making decisions based on what the patient would have wanted or what is deemed best for the patient. Now, when you have a large family trying to tell you what the patient would have wanted, sometimes it is extremely difficult for them to have a consensus. And of course, this may lead to conflict or poor decision making. Then we go to the aspects of futile versus palliative care. There are times when we as healthcare practitioners recognize that implementing a particular treatment or management is essentially futile, meaning that when I administer this medication, the outcome will not change or may not change, or may increase suffering for the patient, and therefore we decide not to implement it. However, family members may sometimes view that as not doing everything possible or giving up. So they try to be forceful and say, go ahead and give this, be aggressive, do everything you can. But when we look at the risk-benefit, the patient will suffer more, and we're prolonging the natural death process. So that, in and of itself, may present ethical challenges. So in a nutshell, 4 main things that we have to consider in terms of these ethical dilemmas before losing capacity, after losing capacity. From the patient perspective, patient autonomy from the get-go before they lose capacity. Even after they lose capacity, we need to respect that. The family members, before and after, again, within the family versus the medical team itself, and even disciplines within the medical team, there are conflicts as well. So there are many areas where you can have ethical dilemmas. So what do? If there's any disagreements or issues that we are unable to resolve, then there is the ethics committee. As you've seen in the case, but the hypothetical case, where the matter went to the committee because the family members were having disagreement. The ethics committee function not just for the patient, but also, and the family members, but also for the healthcare team. They facilitate mediation, allow for discussions between the family and the healthcare team, provide emotional and grief support to reduce conflicts, they're able to clarify ethical principles as well, and they're able to highlight the principles that they use or the framework that is used to come to a decision. So they're able to explain simple, basic ethical principles and apply them to the situation and translate this to the healthcare team as well as the family. To some extent, they're able to provide legal guidance, such as explaining the legal authority of advance directives. And this is very important, especially when the validity is being questioned, the validity of the advance directive. They're also able to offer education and resources, as seen in the case before, where Daniel was offered some form of support and education. They're able to educate the family about palliative care, as necessary, is focused on comfort care, and offering resources for better understanding of end of life. So in terms of supporting the healthcare team, this one is very important as well. They're able to assist the medical team with ethical decision-making and managing potential moral distress. We cannot underestimate the moral distress that physicians face at the end of life. And they also allow for long-term follow-up and support, debriefing of the case, and then long-term support, which helps physicians manage or other healthcare workers to manage cases that may come up afterwards in the long run. From a clinical perspective, us as healthcare workers, we need to be able to encourage patients early, have open conversations about end-of-life preferences, as uncomfortable as it may feel at times, ensure that all the legal documentation is in place, educate families about their role as surrogates and/or as proxies, and provide emotional and psychological support as necessary. This may be before losing capacity or after losing capacity. So in conclusion, early advanced care planning is not only a clinical necessity, but an ethical imperative. By documenting patients' wishes clearly and educating families, we as healthcare workers can ensure that patients' autonomy is respected. Clear legal and ethical frameworks do exist that guide decision-making, but it is the support that we provide to families and healthcare teams that truly defines the compassionate care. My call to action is simple. Let's advocate for more proactive discussions around capacity and end-of-life decisions. Early conversations is key, and this ensures that the patient's voice is heard and provide comfort to families and the healthcare team in difficult times. Thank you.
I have a question. Considering that Cayman is so culturally diverse, right, and we have so many doctors from various places, and being a culturally diverse community, is it mandatory for the doctors to be informed of the Healthcare Decision Act? Is it a must for them to be aware of it or not?
Well, it is an act, so I would say that it is applicable, so it would be in the doctor's best interest to be aware of it. Be it mandatory, I'm not sure, but absolutely it would be in their best interest because it is the law, so.
Thank you very much for that enlightening presentation. This is sort of just a comment based on that last question. Anyone that is doing advance directives, I think once they have it in place, needs to make sure that every doctor that they see is aware of this. And perhaps at every visit to the hospital, if you have advance directives there, to remind them, because I don't know if it is easily accessible to every doctor once you go in, to have an appointment or a treatment.
That is in fact true. Part of the purpose of doing this presentation was to start a conversation or continue the conversation that has started, but I think the conversation needs to be louder and to bring awareness and education to not just healthcare workers, doctors, nurses, etc., but also the general public. So as I was mentioning to a colleague of mine who works out in the community health earlier just now, the conversation can start there, on the first point of contact with these patients out in the community that have terminal illnesses, and at some point it may be expected that they may lose capacity, or it doesn't have to be a patient who has terminal illness but expected to have cognitive decline over time. It is important to start this conversation, and the more aware we all are, then the more likely that we will start to see more persons engaging in advanced planning. I'm not sure what the numbers are like in terms of patients that are currently at Jasmine, how many patients actually do have an advanced directive, but it is definitely a conversation starter, and I'd like the conversation to continue and get louder over time. So hopefully by next year, the next conference, we can highlight some figures and say that we're doing much better than the United States at 37%. But the purpose was to start a conversation or continue a conversation that was already started, but it seems to be a little bit lower than we would like. Thank you.
Thank you very much, Dr. Davis-Irons. Some of you may not be aware that Medical Decision Act bill actually Cayman did not have that until 4 or 5 years ago. So people's decisions were reversed by their families on a regular basis. In fact, Jasmine was very much part of the working. 2018 was when the bill was passed. Prior to that, it was not legal. Even though people had advance directives, and you had it with your lawyer's office or wherever, it could still be overturned. So we're very fortunate that we've had this now for 4 years, and it is a precious commodity, and people's wishes should be respected. Okay, so we're now going to move on to our next presenter, who is Dr. Suluki Medina from Miami Cancer Institute Palliative Care Program. She's going to talk about enhancing collaborative care across the specialties, which is very pertinent to our program. She has been an attending physician in the Symptom Management and Palliative Medicine Service at Baptist Health Miami Cancer Institute since 2016. She specializes in interdisciplinary palliative care, collaborating with a team of oncologists, advanced practice providers, social workers, chaplains, and other specialists to optimize patients' quality of life and well-being, and to provide support to patients and families as they navigate goals of care and complex medical decision-making throughout the cancer continuum. Dr. Medina obtained her medical degree at St. George's University School of Medicine in Grenada, the West Indies. She completed her residency in internal medicine at NYU Langone Hospital, Brooklyn, New York, and fellowship training in geriatric medicine and hospice, and palliative medicine at Jackson Memorial Hospital, University of Miami Miller School of Medicine. She is a member of the American Academy of Hospice and Palliative Medicine and has published several research articles in geriatric medicine and palliative medicine. In recent years, she has written on palliative medicine topics related to breast and gynecological cancers, lung cancer, and head and neck cancer. She's been invited as a faculty guest speaker to the Miami Cancer Institute Head and Neck Conference and the Palliative Care and Hospice Symposium at Baptist Hospital. She remains active in medical education and joined the community-based faculty at Florida International University, Herbert Wertheim College of Medicine in 2020. Dr. Medina is fluent in English and Spanish, and we welcome her to talk this afternoon. Welcome, Dr. Medina.
Thank you very much for that very warm introduction, and I really want to thank the event coordinators and sponsors for inviting me to present today. I have no financial disclosures to disclose today. So we're going to be, these are our objectives for this talk in the afternoon. We're going to be reviewing the scope of palliative medicine as it pertains to our practice in oncology palliative care. We also want to explore current challenges and opportunities in palliative care today, which may have been already presented by our prior speakers. We want to also discuss some strategies to enhance collaboration and integration of pal care across different specialty lines. And lastly, we want to highlight just a few features of our program at Symptom Management and Palliative Medicine at the Miami Cancer Institute. So I thought initially we shouldn't be presenting on very long definitions, and I agree with our prior speakers. You know, these are wordy definitions, but I think for the sake of the general public or individuals in the audience who may not be as familiar with palliative care, I'm particularly going to focus on the CAPC, or the Center to Advance Palliative Care definition. And basically, this is a national organization in the U.S. who's working extensively to expand palliative care access in the United States. And so basically, they define it as specialized medical care for patients living with very chronic serious illnesses, focused on providing the patients and the families from relief from pain or stress brought about by a clinical serious illness. The goal remains to improve quality of life, as mentioned before, to both that patient and the family. Palliative care specialists work together as a core interdisciplinary team to provide that extra layer of support to either a PCP or an oncologist. And it's really appropriate at any age and at any stage in the course of a serious illness, and it can be provided alongside curative therapies or treatments. So I like this graph. It's a conceptual model of palliative care delivery. There are many that you can come across the literature, but I particularly like this one. It's called the bow tie model of 21st century palliative care. And typically, it's a conceptual model that illustrates the integration of palliative care throughout the continuum of a patient's illness. You know, in my specialty would be in the cancer trajectory. So as you look on the left-hand side, typically at the onset of a diagnosis of cancer, for example, there is a very good role for integrating palliative care initially to really start providing that support and that symptom management to improve that patient's quality of life as they go through the cancer treatment so they have better outcomes. Toward the middle of the graph, as perhaps that disease may progress and patients may not respond as favorably to treatment, there is a more balanced input of palliative care at that time where we really heavily start engaging in our advanced care planning and our goals of care settings and really start honing on what's really important to the family and what their priorities are. And as we progress further to the right-hand side, as our patients become more chronically ill and start declining, then we really start focusing on a more comfort-based approach and initially having that very warm transition to hospice when that patient and the family is ready. So I think for the sake of education and also for our audience members who may not be as clear as to what the differences are between palliative care and hospice, I wanted to really present this slide. And so essentially, I think the philosophy of palliative care and hospice is essentially the same. There are some very minute distinguishing factors between the two. For instance, palliative care, we know can be provided during any stage of a critical illness. It could be delivered alongside curative therapies, whether the patient is receiving dialysis or is having cancer treatments or is a heart failure patient. It can be provided in the clinical setting, typically, also the hospital setting, sometimes a home-based setting. And it's really based on a particular need. It is not based on prognosis. So we don't shut out patients that are not stage 4 cancer patients, for example, from receiving palliative care. We really like to offer that early upstream. On the contrary, hospice is really utilized when a patient's prognosis is 6 months or less. We start really to implement that when patients have failed treatment lines or they're no longer responding to any curative treatments. If that patient also desires to have a more comfort-based approach to care, and typically is provided in the home setting. And this is where really patients want to be treated. Now, of course, what they have in common is that they're both very, very good at supporting seriously ill patients, really decreasing that symptom burden by having aggressive symptom management on board, really enhancing that quality of life, and really providing substantial support to family members and caregivers. And so this slide focuses a little bit on the scope of practice of palliative care in general, but this is really as it also pertains to our practice. And so palliative care is really a comprehensive model of care that not only focuses on the biological basis of an illness, it really addresses all of these different components, of care and, needs that patients have, whether it's in the physical domain, the emotional, psychological, social, or spiritual. From a medical standpoint, what I tend to do the most at the clinic, our heavy referrals really come for pain management, specifically for cancer pain management. And, we're also very, equipped to manage other symptoms that, may come, through the course of, patients getting cancer treatment, like a lot of nausea, anorexia, constipation, all these very common symptoms that palliative care patients can experience. A word on pain management, as it was illustrated by one of our audience members before. Our clinic is very, very responsible with opioid prescribing. The vast majority of our patients are on heavy opioid therapy because they need it. But, we are very responsible with prescribing. We're always counseling on safe prescribing practices, no medication sharing, no opioid diversion. We also counsel our patients on the risk of accidental overdoses, as we frequently co-prescribe other CNS depressants like, for example, gabapentinoids or benzodiazepines to really provide that good symptom management. And so we do this very diligently, and we educate our patients constantly. We also co-prescribe naloxone when it's appropriate if there's a high-risk patient or there's a higher risk of an accidental overdose. And so we're very responsible with that. We're also very adept at managing emotional symptoms like depression, anxiety, insomnia. Also from the spiritual and cultural parts of care, we really heavily enlist our wonderful chaplains and social workers to really help us address patients' existential needs, whether they have fear of the unknown, fear of death. And really we try to really provide care that's very culturally sensitive and really respecting their values and beliefs. From a social and practical point of view, as illustrated by our prior presenter, we're very heavy with doing the goals of care discussion, sometimes very early on, depending on when we receive that referral. We engage in extensive advanced care planning, end-of-life preparation, that coordination of care across different entities when patients are discharged from the hospital, they're coming back to a clinic, or they're going to a nursing home or a rehab facility, for example. But of course, we couldn't do this alone. I'm just a physician. I rely on a big interdisciplinary team to really provide this best level of care. I wanted to shift a little bit to talk about some challenges that we're experiencing in our country that I think are really hindering the effective palliative care delivery and dissemination across the healthcare system. As it has been alluded before, we understand that there's a workforce shortage, in the U.S. and probably worldwide on palliative care specialists. Quite frankly, there's not enough of us. There are not enough trained professionals, and that really limits, access to patients, especially in rural and underserved areas. As alluded also before, there's significant lack of education and training, really in all healthcare professionals, in all lines of, whether it's in nursing, social work, there is a paucity of palliative care education, and really this resulting in inadequate care and poor communication and poor symptom management. Now, we also recognize there's a lot of cultural and societal barriers that hinder us from really delivering effective palliative care, and there are many misconceptions really at the physician level, the family level, the community level, the healthcare system level. And again, this often, because we're seeing as typically an end-of-life service, which is quite unfortunate, and patients don't really elicit our services on a regular basis, and they're often very hesitant to accept their services because of these common, misconceptions that are out there. Other challenges that we experience are inadequate funding and inadequate resource allocation. We have very limited financial support and, poor reimbursement, and really in favor of more curative treatments and that kind of aggressive approach to care. There's also issues with integration of palliative care across all service lines. And this really creates inherent difficulties as, palliative care care in general becomes very fragmented. There's poor collaboration, with palliative care doctors, oncologists, nephrologists, and that really, ultimately, the patient pays for that because there's poor patient outcomes. Again, at the family level, there's lack of awareness about palliative care in general. I can go to any social gathering and ask, anyone in the audience, who knows what palliative care is, and I think most people don't know. That's a big issue, and typically delays, access, as many families are not aware of how much and how many great things we could do for patients if they only elicited our services. So, we're going to be discussing some strategies that I hope can mitigate some of these challenges that we're experiencing in our country and probably also worldwide. I think the important ones that I've come across would include strengthening education and training, creating more collaborative care models to integrate palliative care, integrating palliative care in the day-in clinical practice, and also advocating for changes in policy and really having more leadership support to expand our services in general. And also maybe engaging benefactors and philanthropists, for support to extend palliative care, hospice in general. So in terms of education and training, I really argue, and I'm super pro incorporating palliative care education earlier in medical training, nursing training, early allied health education, really as a core requirement in the curriculum, really emphasizing those good communication skills, symptom management, and end-of-life care. And this will really help to home in those primary palliative care skills that I think we all need to have, because I think this is probably the best direction to go, because there are not many of us to go around. And so it really turns into that primary palliative care, that education, in that part of the education. Also creating interdisciplinary training programs that could train, doctors, nurses, social workers, and hopefully has, collaboration, and so they can have a shared understanding about palliative care principles. Also providing on-job training and mentorship when we're already in clinical practice, again, to really promote those primary palliative care skills. Our national organization to promote palliative care and expand palliative care is called the Center to Advance Palliative Care. That's headed in New York City. Typically, I would recommend that as a resource, but unfortunately it's not a service that's free of cost. It's really more relevant to clinicians in the States. They have wonderful tutorials. They have CAPC designations that providers and any allied health professional can complete and get that CAPC designation. And they have many different pathways, and you can put that on your CV and you acquire their skills without having to do a hospice and palliative medicine fellowship, for example. So let's talk a little bit about collaborative care models that will help to integrate palliative care a little bit more. So the creation of more interdisciplinary teams, like the core palliative care IDT team, to work with oncologists and other specialists to really deliver comprehensive care. The consultation services, these have been very, very successful, ways to access palliative care, but these are typically delivered in the hospital setting, but it really does allow specialists to really request our services when they're needed. Creating regular IDT case conferences. This is a great opportunity to really review those very complex patients, and I would argue to really ensure that palliative care is already part of the treatment plan. We shouldn't be really called out at the last minute. We should be involved from the very beginning. We really need to make sure that for these complex patients that we're on board and that the care is aligned, also with our patients and family values. Shared decision-making that can involve the patient, the family, really the whole IDT team, the entire treating team, to make sure, again, that medical plans align with the patient's goals and preferences. So integration of palliative care in general, on-site at the clinic visit. So I would argue that, these are, would be very helpful strategies, like doing a little bit of screening at the clinic during the clinic intake, where we could really help to identify, patients with advanced disease or advanced cancer, or even set more clear referral pathways or guidelines for timely access. I like to ask the surprise question. I think, I don't know if everybody's familiar with it, but I think it's, would you be surprised if this patient were to die in the next 12 months? If the answer is, I wouldn't be surprised, these people really need palliative care desperately. Embedding palliative care clinics in specialty clinics like oncology, heart failure clinics, that would be also a very good strategy to identify patients who can really benefit from our services. Providing more routine assessments at regular clinics. In our clinic, we like to use the ESAS, tool to really assess the severity of symptoms when our patients come to the clinic on a monthly basis. Also encouraging earlier referrals to our services in general, especially as you see that patients are more chronic and their illness is progressing and they're probably near the end of life. Let's shift a little bit to focusing on policy and leadership support. Definitely there needs to be many changes in healthcare policy to really disseminate palliative care across the healthcare system in our country. So we can promote establishing institutional policies that could help integrate palliative care as a mandatory consultation, or perhaps embedding a trigger in an EMR, an electronic medical record, to really identify those patients that are very high risk. Leadership endorsement to obtain support from healthcare leadership to really champion the role of palliative care in our chronic care services. We need to, promote resource allocations, to staff palliative care clinics, hospice programs, and really to have that access more available to patients. I like to think that philanthropy probably has a role, in helping out to expand palliative care, as you have seen in your experience here with Jasmine. And maybe, having, more philanthropic support, to start programs, fellowship programs, home-based, services, and more community outreach programs. We could definitely use donations to start, training programs, and also to start meaningful research in palliative care, in pain management, in communication skills, and really to innovate new palliative care models. Contributions, again, can really be used to expand palliative care and hospice in general. Let's shift a little bit and talk a little bit about our palliative care program. And so this slide illustrates, basically palliative care is well integrated at the institution that I work for. And we have come a very long way since I started working there in 2016. So on the left is, our team at the Miami Cancer Institute. We are a small clinic embedded in an oncology clinic. And, we have 3 physicians. We have 3 wonderful APPs, a dedicated social worker, wonderful MAs who function almost like nurses. And we have one of our colleagues provides, services at a satellite clinic that's north of us. We have a robust palliative care consultation service in the hospital, at Baptist Hospital. That one is a much bigger team. I think it's 5 doctors, 4 APPs, 3 or 4 chaplains. And, we work really collaboratively with that team. I don't see patients in the hospital, and they don't see patients at the clinic. And so this is the team that we rely on to take care of our patients when they need to go in to get on a PCA for aggressive pain management that's not responding to oral meds, for example. So we have a very robust relationship. We talk every day. We have a very collaborative relationship, and we, really I think we're doing a good job taking care of our patients. This is just our policy for palliative care. I'm not going to go into that because we've already discussed this already. It's really more like the scope of service that we talked about before. These are our referral processes, and they're really more for domestic patients. That's just the upper part is the pathway to generate that referral from the clinic, and the bottom part would be to generate the referral from the hospital setting. For any questions about referring international patients, I would invite you to contact Baptist Health International, for that pathway is completely different than the one that I use on a regular basis. So when we're thinking about initiating that referral, I think it's important to understand, who is a great palliative care candidate, who are those patients that could really benefit from palliative care. These are just some of the criteria that we use. We typically like to help and see patients that have uncontrolled symptoms, whether they're physical, psychological, clearly patients with advanced disease, whether it's advanced cancer. Sometimes I see patients with a new cancer diagnosis, but they have advanced cirrhosis. And so all of these complex patients with multimorbidity are ideal candidates to be seen by our clinic. Patients with very poor functional status, functional decline, patients that are going to the hospital pretty much on a weekly basis are great patients for us to see, and patients with a prognosis of 12 months or less. I think it's important to also discuss, who is appropriate for hospice, and the only reason I wanted to bring this up is because routinely we get referrals to see patients in the palliative care clinic who should be really enrolling in hospice the following day. And so I think it's important to educate our providers in our setting, when to really refer to hospice and when to refer to us. These referrals are for patients that cannot wait, that are imminent and could really use the services right away. So we really do this so that we don't delay good, adequate hospice care. And so again, patients with, uncontrolled symptoms, very advanced disease, heavy dependence on ADLs, they're essentially bedbound, they really can't do anything much for themselves anymore. Patients with very rapid functional decline, very poor prognosis, and of course, patients who want more comfort-based approach and are nearing the end of life. Just to share some referral data from our clinic, on the left-hand side, these are the numbers of unique referrals that we received in 2022 and 2023. I'm happy to report that every year we continue to get more referrals. Since the onset of the clinic in 2016, that number continues to go up, which is great. I think it's a testament that I think we've done a very good job taking care of our patients, and we're receiving more referrals from medical oncology on a regular basis. And so we had a nice increase of 13.8% in referrals in 2023. On the right-hand side, these are the unique referrals by disease site, by tumor sites. And our top champions and our top referring teams are the GI team, the breast, GU, and head and neck. These are really our top referring teams but GI is really our champion, at our clinic. Those guys refer quite a bit. This particular slide talks a little bit about the medical visits. And so we do a portion of telemedicine visits. We also see the vast majority of patients we see in the outpatient, which would be live visits. We started to shy away a lot from telemedicine after the pandemic because we really felt it was important to see those patients in the clinic because, we don't really miss things on a regular basis. We're able to do more, at the onset of the clinical appointment. We're able to call the pharmacy. We're able to establish, opioid delivery. We're able to do so much at the clinic on site versus having to perform so many phone calls when we see them of telemedicine. So in 23, we had a total of 4,911 encounters, or we're nearing 5,000. Of those, 787 were new patient visits. That was a little bit of a decline in that, and I think that's probably because we kind of shied away from doing telemedicine, so patients, felt that they really wanted to be seen that way. So I think this may have something to do with the fact that we saw a fewer less new patients this last year. But for the most part, we're continuing to see more patients every year. So the top reasons for referral are obviously for pain management. That's a big one. A lot of advanced care planning and goals of care setting, and also, non-pain symptom management, typically for side effects related to cancer treatments. These are some of our initiatives at the clinic. Again, we're not an academic program. We're like a hybrid community, clinical, academic program. And so we're making some strides to, include more medical student rotations. We've become a little bit more active in publications, and also participating in some of these community events with the different symposiums that we're having in our organization. And so these are some of the things that we've done in the past year and a half or so. Let's shift very quickly to some updates that are pertinent to the talk. This year, there has been a Telehealth Modernization Act that was introduced, which would make Medicare, that's just one of our governmental insurance plan, payments for telemedicine visits permanent because there's always a risk that those telemedicine visits are going to go away and patients are not going to have them. And so I think Medicare is looking into making those permanent, which will really favor palliative care, because then we will really be able to see those patients that cannot come to the clinic, and it really would help to broaden the access of palliative care in general, particularly in patients in underserved areas. There's always a bigger shift toward a value-based care model, where Medicare Advantage and other plans are helping to integrate palliative care into broader health systems to really, kind of do away with that traditional fee-for-service model, which doesn't really work well for palliative care patients. There is a rising demand for palliative care services in general as our senior population continues to increase every year. There's really a strong need for home-based palliative care programs. So there are some initiatives to help offset that, because we're going to have a big problem by 2050. We're going to have a lot of elders in our community. Other governmental plans like Medicaid are also incorporating palliative care coverage, offering revenue for palliative care providers, and really expanding the services to patients that need it the most. So some take-home points for today's talk. We know that interdisciplinary palliative care can improve patients' and families' overall quality of life by providing that really expert, robust symptom management, providing relief from psychological stressors, adding social support, helping patients and families live a more comfortable life in general in the face of a life-limiting illness. We know that palliative care interventions help to reduce hospitalizations, emergency room visits, unnecessary or aggressive treatments, and in some instances, as stated previously in the prior talk, palliative care sometimes can extend life, as it was seen, I think, in the Tamil study. Palliative care specialists assist, patients and families in shared decision-making, really allowing for more thoughtful decisions regarding treatment options and ensuring that patients really receive the care that's aligned with their values and preferences. Palliative care specialists assist in a lot of advanced care planning end-of-life preparation, transitions to hospice, ensuring that that patient really gets good comfort and dignity toward the end of life. I typically continue to see patients that still enroll in hospice because they've been mine, for years, and it's really hard to let them go, but also to reassure them that hospice, with that transition, they're going to do an excellent job as well. They've been so used to us for years, and we really tend to continue those visits until they really integrate with the team and they start welcoming those resources at home. And so we really honor that, whether we get paid for it or not. We still continue that. Some challenges facing palliative medicine today include addressing the workforce shortage that we have worldwide, the rising demand for palliative care services, limited education and training, the societal barriers that we discussed before, and also limited funding for our programs. Some strategies to enhance collaboration and integration of PAL care in the overall healthcare system can include, again, reinforcing the education piece, the training, building better collaborative models, communication and promoting that culture change, having more dialogue about our services, and hopefully changing policy and eliciting leaders to really, fund and promote palliative care. The Telehealth Care Modernization Act is promising, as it can mitigate some of these challenges by increasing the access to palliative care for patients in underserved areas. And these are some resources for you and now for family members. And thank you for your attention. I welcome any questions.
Thank you. I didn't get to ask much questions when I was in school, so I'm taking the opportunity. Thank you so much. Thank you so much for that presentation. I hope I get that presentation, if you don't mind. Let me hold it. The battery is, all right, thank you. That works, awesome. What's interesting for me is that last Friday at the Doctors Hospital conference, there was a team that spoke about collaborative cancer care. And what was really interesting to me is the scenarios that they gave. The third scenario with the individual who's terminally ill, right? The problem with insurance. Yeah. Now my thing is, in terms of policies, right? What would you suggest? What would you recommend for those who provide insurance, because this collaborative care can rack up serious dough, and a lot of people, especially in amongst our vulnerable, the vulnerable people in our community, cannot afford some of the services because you made mention, and I like the diagram with the spiritual and the emotional, psychological, and the other aspect. But what if persons cannot access the counseling that they need, or some of those extra, resources? What would you suggest to the policymakers?
Great, and that's a very challenging question. I can tell you from my experience, sometimes we take care of cancer patients that are illegally in the country. They're undocumented, and many times we can enlist the social workers and case managers to help us obtain charitable hospice, and some of the hospice agencies are willing to do that. In terms of a broader, policy at the policy level, I'm not sure, what would be recommended. I don't know if anybody has any experience with that. For patients that can afford hospice, what would be
one of the reasons why I asked that question is because
yeah.
takes people out more than anything else, because they're
Right.
thinking, I'm here for weeks and the money keeps going up.
Right.
And who's going to pay it?
Got it. I'm not sure what the situation is here in Cayman or the Caribbean, but in our country, we have public, hospitals in place, and there's a system in place so patients who are at the end of life who need, for example, inpatient level of palliative care, get the care that they need. They're not gonna be not taken care of. I'm not sure what the structure would be here in the Caribbean. Okay. Right. Okay, that's great. That's great. Well, thank you.
Yes, which is just a reminder to say how lucky we are to have free palliative care here, irrespective of means, and also we don't use insurance. Now, some people have argued that we should use that as a way of raising income in the future, and it is something we've looked at, but, you know, we've got great flexibility in the system that we have. We just have to raise money. So that's where in a small community where people are very supportive, we're fortunate like that, and we don't have to, we can choose who we want on our service. We have no sort of barriers to that. So thank you very much for that presentation. And we're now going to move on to our final speaker before the break. We're running a little bit behind time, so can I just, after this, this speaker who's actually going to be online, can we all make sure that we're back from the tea break at 3:30? Yeah. So I'd now like to introduce our next speaker who, as I said, is online. Dr. Caroline Cubbison is coming to us from Dana-Farber in Boston, and she's going to talk about navigating communication preferences during times of medical uncertainty. Thank you very much to Dr. Cubbison for filling in at the last minute due to some unforeseen circumstances with the other speaker. I'd also like to remind you about the online viewers doing your CME forms. So Dr. Caroline Cubbison is a board-certified physician in internal medicine with advanced training in palliative care. She completed her fellowship at the prestigious Harvard Interprofessional Palliative Care Fellowship Program in 2023. Raised in the Dominican Republic, she is fluent in Spanish and brings a deep personal commitment to addressing health disparities within palliative care, particularly in underserved communities. With a focus on providing compassionate, patient-centered care, Dr. Cubbison serves patients both in hospital and outpatient settings. Her bilingual proficiency allows her to connect with and support a diverse patient population, furthering her mission to make high-quality palliative care accessible to all. So we now hear from Dr. Caroline Cubbison.
Good afternoon, everyone. My name is Dr. Caroline Cubbison, and it is my absolute pleasure to be able to join you today, even from afar, in this very important palliative care conference. I'm a palliative care doctor at Dana-Farber Cancer Institute in Boston, where I see patients both in the outpatient and hospital setting. Today, I'm very grateful to have some time to share with you a topic that's very important for me, which is effective communication and how we navigate that during times of medical uncertainty to make sure that our patients and families feel well supported. Our objectives for the day is I'd like to highlight the key differences in communication preferences. In fact, this may be the first time that we're exploring some of these. I'd also like for you to be able to recognize a framework for effectively delivering medical updates and also retrieve a method to disclose prognosis even while navigating medical uncertainty, when there may be a variety of different outcomes and we don't know exactly what might happen. It's always important to link this work back to the biggest myth there can exist about palliative care, which is that it's only for people who are very much at the end of their life. When in reality, we know that more and more studies are coming out demonstrating the importance and value of palliative care earlier during a patient's illness course. And I think a lot of that value does come from effective communication and helping patients and families prepare for what's to come. Also, sort of taking a step back, this all stems back from the origins of palliative care and what it is and what it intends to do. And for me, palliative care really means that we are hoping to alleviate suffering. And we know that suffering comes from many different dimensions. In palliative care, we like to take a multidisciplinary approach. That means that it's not just up to the doctor, but it's really about embracing a team of nurses, social workers, chaplains, or spiritual leaders to be able to address all the different areas of suffering that a patient and their family or loved ones might be experiencing. And one of those domains really is in communication support, which is going to be our topic of conversation today. What do I mean when I say communication support? I mean several things. First of all, it's really about understanding how we should be communicating with patients and their families, because this isn't a one-size-fits-all. Everyone's a little bit different. And then how do we make sure that we are conveying our messages and our information, our medical information, effectively. Let's start with a simple reflection. I'm wondering if you can think back to previous conversations that you've had with patients and their families, and just think for a moment, what has gone well in the past when you have communicated with patients and families? Are there certain things in particular that you notice make these conversations easier? At the same time, what has been challenging? If you think back to those difficult conversations, I know that we've all had a difficult conversation in our time as, medical treatment teams. Think back, and I wonder if you can really analyze and reflect, why was that encounter challenging? Was it because of the emotion? Was it because of different interactions between different people in the room? What was it? And do you know some key steps that you are currently taking when you're having these conversations? I think we all develop our patterns and our behaviors about how we speak and communicate with people, and recognizing what our pattern and our default is an important first step to be able to identify our rooms for growth. Now, what we know is that clinicians report a lack of training. For all the training that we get in medical school and for all the experience that we have, we really don't have a lot of training specifically about how to talk to people and how to communicate and make sure that we're communicating effectively and well. We worry about upsetting our patients, especially in our work when we unfortunately are dealing with very serious illness. It can be hard and devastating to have to share some of the news that we have to give sometimes. But we also know that effective conversations improve patient-level outcomes. We know that patients and loved ones and families, when they're informed, they're able to improve their feelings of quality of life and make better decisions that help them receive the kind of medical care that they want for themselves. And most importantly, we know that these communication skills are teachable and learnable. I think one thing that we hear a lot in palliative care is that, oh my gosh, you are so gifted, you have such a great way of speaking with people. But the truth is that anyone can speak to patients in an effective way. It's all about just practicing and trying some different strategies out. There are a couple different steps that I think about as we prepare to have an effective conversation. The first step is to really explore the communication preferences that a patient and their family or loved ones have. And we'll talk more in detail about how to explore that. Then, once we understand that, it's really important to ask what they understand from their medical condition or their health up until now. After we have an understanding of what they know, that's when we're able to effectively give and tell them the information that we need to tell them. And we need to be able to expect and respond to emotion, which inevitably will come up. It's normal for emotion to come up when patients and families are receiving information. And we would also like to ask for permission to talk more and take the conversation further after delivering news. Let's focus on that first step, which is exploring communication preferences. And maybe some of you are thinking, what the heck does this person even mean when she's talking about communication preferences? Well, let me give you a couple of examples. Not every patient can accept or understand information in the same way. Think about back when you were in school and you were learning. There are some people that learn better by reading things, and there are some people that learn better by seeing things and drawing. And there are other people that learn better by, hearing things. And so just like there are different learning styles in childhood that we recognize, I think communication preferences are similar to that too. I've noticed that there can be significant differences, and it's important to be able to talk about them with our patients and really get a sense of what works best for them so that we're giving them information in the way that is easiest for them to receive and understand it. One such difference is there seems to be a group of patients who really appreciate understanding sort of the big picture much better than specific details. Because if we give them too many small details, numbers about specific electrolytes or specific measurements on scans or x-rays, those minor details can be confusing, and maybe they don't totally understand it and they can lose sight of what's really going on sort of if you zoom out and look at the big picture. Meanwhile, other patients tell me that they really do need that kind of specific level of detail in order to make sense of the big picture, and they can't understand the big picture without it. So that's one such example of a difference in communication preferences. Another difference is there's a group of people who might say that they want to receive all medical information first, and then they want to be able to control how much information they share with their family or their loved ones and when. Whereas other people, especially as I reflect back onto my own culture as a Latina, I know that a lot of patients want us to actually be communicating to their families first and sort of let their families be the ones to share them the information that they feel is important. And so that's a big difference too. And you can start to see that if we don't understand these things, we might take a wrong step in one direction or another in giving information in a way that is not understandable or not well received. Another difference in communication preferences are people who tell me that they want to know about their prognosis. And even the way that we frame prognosis can differ greatly depending on what someone is prepared to hear or wants to hear. There are some people who tell me that understanding a prognosis in terms of how much time their medical team thinks that they might have is helpful because that helps them plan specifically for certain events that might come up along that timeline. Whereas other people tell me that it's more important for them to know not so much how much time we think they might have, but how we expect they might feel. You know, do we expect that they're going to need more help? Do we expect that they're going to need, physical therapy or assistive devices to be able to walk and be independent? What is that time going to look like? Instead of just a number, say 2 months or 6 months or a year. But what is that time going to actually look like might be more helpful for some patients. So that's another example of a communication preference difference. And so once we understand a person's communication preferences, I always like to take it a step further and just ask my patients, other than you, are there other people we should be communicating with? And then, as you might assume, we have to figure out what that other supportive person's communication preferences are, because they might not be the same as our patients. I'd like to give you a couple of patient examples just to illustrate the importance of this. I'd like to share the example of one of my dearest patients. She has very advanced colorectal cancer. And she told me during one of our meetings that she didn't want to know what her prognosis was. That information was too frightening for her. And she was really worried that if she knew that in her heart, she wouldn't be able to live a normal life and be able to enjoy every day with her family the way that she wanted to. So she didn't want that information at all. At the same time, she wants to help support her family through her illness. And her husband told me that actually knowing her prognosis was really important for him because by being able to understand how much time they might have, he could then help prepare their children and make sure that they were supported throughout that time course. So this is a great example where there are two different information and communication preference needs and requests from two different people, even though they're in one same family unit. And how we navigate that and communicate to everyone in the family will be important to both protect our patient and also help her support her family, which is also another one of her goals. And so in this case, what I ended up doing was obviously I got my patient's permission to speak with her family privately to share any information that they would find helpful, which she thankfully allowed me to do. And by that, we were able to prepare her family as best we could for what was to come, while still protecting her own wishes and her own sort of mental health as she was navigating serious illness. Another example is when patients are in the hospital all the time, and there are many different complicated things going on, and things are changing day by day, and they're seeing many different doctors, and a lot of information is coming around. And many patients, again, depending on the cultural background, might actually tell me that they want all information to flow through their family first, and that they really trust that their family knows what's best for them and will let them know what's important. Because receiving too much information independently as they're sort of healing and recovering from everything that's going on in the hospital can be very overwhelming. And so this is another example where you really need to be in tune with that, because it would be easy to not know that and overshare information and over communicate, which can also be detrimental to patients. So once we have elicited and truly understand what a patient's communication preferences are, it's critical to really obtain an understanding of what their illness understanding is. And so some example of phrases that I like to use are just to ask the patient, remind me, what have we talked about so far about where things are at with your cancer or with your dad's cancer, for instance? Or what have you heard the other doctors tell you about what's been going on in the hospital? I think by asking patients and families what they understand, that really gives us an opportunity as a medical team to see where the different information gaps might be. And we can quickly assess, okay, does this person have a very good understanding of how they are doing? Or do we really need to start way back and start to fill in some of those information gaps so that they can make sense of the news that we need to share with them now? And that's a critical step, because sometimes if we don't do this and we don't check for the patient's illness understanding, we can give a medical update that isn't grounded on a good past medical understanding. And then patients and families don't know what to do with that information because they don't understand how we got here. And so this is all about building that foundation so that patients and families understand how we got to where we are. Once everyone sort of understands where we are, it's time for us to tell information. And the trick that I would like to teach you is to use what we call a headline. And so a headline, if you think about the newspaper, it's the biggest thing on the top of the newspaper on the front page that is what you're going to take home and what you're going to remember most. Another way to think about it is, after you finish your conversation with your patient or with their family, when they pick up the phone and call whoever they trust most to tell them what you just shared, what is it that you want them to have taken away from that conversation? And so this is really about coming up with maybe 1 or 2 sentences at most with the ultimate news that you want to share in a way that does not include a lot of medical language and is easy to understand. So, for example, a headline could be for one of our cancer patients with progressing cancer: the scan shows your dad's cancer is growing, and I'm worried we don't have other good treatments left. And as you can see, that is a short sentence, but it carries a lot of weight with it. And it's something that is easy to understand, doesn't have a lot of medical complex language in it. And so anyone could hopefully understand that and really understand how serious it is. And we'll talk about how we can provide more information after the fact. But the most important thing is to be sure to be using a headline that is easy for people to understand when you do give them the medical news update. After you give a medical update, most of the times we're sharing really important information, and we want to check in with patients and families before we keep talking, because it's all too common that I see medical teams just talk without doing an assessment and checking in with the patient and family to see if they're okay or if they need a moment to break and pause before we keep talking. So the way that we like to do this is to use what we call a permission statement, which is where we're going to just ask permission to see if it's okay to continue the conversation. And so after your headline, you might take a pause for a moment and then just ask, is it okay if we talk about where we go from here? Carry the conversation forward. Sometimes patients might tell you, or families might tell you, I'm not ready to talk about that right now. And that's a good sign for us to say, okay, why don't we pause here and then we can come back to this conversation at another time. But sometimes patients and families are ready to hear more and want to talk more. And that's our cue that we're able to continue the conversation. During this process, of course, emotion is going to come up as part of what people express, especially when receiving medical updates that many times can be difficult to hear. When we're responding to emotion, there are a couple different steps that are really critical. The first one is we just want to name it, right? So when you're talking to a patient and you notice that they're feeling overwhelmed or they're feeling sad or they're feeling frustrated or angry, oftentimes the best thing that you can do is to just recognize it and name it. This must be so overwhelming. I can tell that you're frustrated. That just lets them know that you understand and you see how they're feeling in reaction to the news. You want to follow that with a statement that, again, shows that you're aligning with them and that you understand where they're coming from. So an example might be something as simple as saying, I can only imagine how you must be feeling. We also talk about trying an I wish statement to sometimes, again, show that you empathize with them. I wish things were so different. I wish this wasn't the case. And then again, we want to open the conversation back up to hear from our patients and their families and their loved ones what is really on their mind and what's most important. And so that's when I would say something like, tell me more. Tell me more about what's worrying you. Tell me more about what's on your mind after you hear this information. And just see where they take the conversation. In difficult conversations, when we're sharing medical updates, I think we ignore the emotion all too frequently, and we go down a cognitive pathway. And we need to be watching for emotional cues. A classic thing that we hear over and over again is the phrase, there must be something more that you can do, or are you sure that there's nothing more that can be done? I think these are normal and expected reactions that also reflect back the distress that a patient or their family or loved ones are feeling at the time. It's easy, and in fact, we've been trained in medical systems to go down a more logical cognitive pathway and say, oh, if they're asking, is there something else that we can do? They're asking specifically about testing, about consultations with other specialists. And so let's go down everything that we've already done. And so it's easy to fall into that trap and just repeat, well, again, we've given him chemotherapy, immunotherapy, radiation, and he's continued to get worse. At which point the family might come back and say, well, maybe we need a second opinion. And then you can see how that goes down another pathway of more treatments, more workup, more investigation. Whereas another way to look at this question is to recognize that this might be an emotional cue and a sign of distress. And maybe we just need to recognize how difficult this situation is right now. And so a different way to approach this might be to respond to the question of there's got to be something else you can try. Maybe we say something like, this is so difficult. I can see how dedicated you are to making sure that your father gets the very best care. And then maybe the family will open up and just let us know how they're truly feeling. I'm just not expecting this. I'm not ready to lose my dad. This is also sad. And so it's very different. And sometimes I also feel like in conversations with patients and families, when they keep bringing up the same questions over and over again, that's often not so much a sign that they haven't heard or don't understand the cognitive pathway, but it's more of a sign of their emotional distress and that we really need to be addressing that more than focusing again on the cognitive information or data that has already been shared. Because it's really the emotion that's sort of being a little bit of a block to be able to move forward and think about what comes next. So as we get closer to wrapping up, I would like to talk about how we can think about communicating with patients and families during periods of uncertainty. What I mean by this is that many times a patient or their family member will be along for this medical journey and will be trying a treatment, and there might be a very wide range of possible outcomes. And we're not sure exactly how the patient might respond. And it can be really difficult, I think, as a medical team to feel like we have the confidence and the certainty to know exactly how something might go, which makes disclosing prognosis very, very difficult. And at the same time, I think it's important to share with patients and families what we think might be most likely so that they understand that there is a range of things that might happen, but so that they can also prepare emotionally and in any other way that they need to. And so this kind of framework was actually started for patients undergoing surgeries when the surgical outcome might not have been totally understood or known before the surgery. And it's called best case, worst case, and most likely, where essentially, before you talk to the patient, it's important to really think this through. But what do you think the best case for this patient might look like if they continue with this treatment plan? And contrarily, what do you think the worst case is for this patient? And between those two extremes, between best case and worst case, where among that spectrum do you think is the most likely outcome? Because while we can agree that there's a range of outcomes, I think we can also agree that medically we probably feel that there is a more likely place on that spectrum for our individual patients. And so, again, being able to convey that, I think, gives us the confidence of both recognizing that we are limited in our ability to prognosticate with certainty and that there is a lot of variation and variability in medicine, and there are outliers in medicine. And at the same time, from our medical experience, we think that one thing is probably more likely to happen. And that will help patients and families prepare for those different outcomes. And just hearing that, I think, is really important. So I hope that the next time that you have a really challenging case with lots of medical uncertainty, you can reflect back and think about this best case, worst case, most likely framework and just try it out. I have found it to be very, very helpful, especially with patients who are critically ill, needing very intense care in the hospital setting, or who have been in the hospital for long periods of time. So with that, I'd like to thank you for giving me some of your time this afternoon. And I welcome any communication or conversations. You can reach out to me. It's been an absolute honor to be able to present this to you all today, and I hope that you have a wonderful conference.
And so this is a half-hour break now, and if you could all be back by 3:30, there is tea and coffee, and it's snacks. Yes, snacks are available there, so please help yourselves to those, and we'll see you back at 3:30. Hello, everyone. Okay, that was more than a 5-minute break. That was a 10-minute break. Okay, before we have the next speaker, I would just wanted quickly to introduce you to the Jasmine team, because it has changed somewhat in the last few years. The first person, I'd like to introduce is our Director of Operations and Nursing, Mosley Brown. She has entered the large shoes of Felicia, who left us, McLean, has left us to become the Chief Nursing Officer of the Cayman Islands. So we're very delighted to have her here with us today, as she was with us for 20 years. So the next group of people I'd like to introduce to you are our nurses, the backbone of what we do. Heather, would you like to stand up? Heather Hazinga. Everyone knows Heather. Heather's been here as long as Felicia, or maybe even slightly longer. And she comes from Northern Ireland. And then we have Edward Buchenje, who is from Zimbabwe. And our newest recruit nurse is Kate Irvin, and she's from the north of England. Okay, then we have our amazing carers. Gloria Reed, who's the longest serving employee of Jasmine. She's been with Jasmine since its inception. She's the boss. And then we have Sylvia German, who's been with us for very many years as well. Hey, Sylvia. And then we have Doneth, who's been with us for quite a few years too. Then we have a new fundraising team, and they've done a fantastic job organizing this afternoon. And that's Sophie Munden and Steph Prieto. Okay, and actually the newest recruit is our next speaker. Dr. Lauren Goodman has joined Jasmine as palliative care physician, and I'm going to read her very impressive bio to you right now. If I can find it. No, that's Dr. Donna. Sorry about this. Here we go. Dr. Goodman completed her medical school at, as I said, Ohio State University College of Medicine in Columbus, Ohio. She remained there at the Ohio State University Wexner Medical Center for residency in internal medicine and for fellowships in hospice and palliative medicine and in pulmonary and critical care medicine. She was on the faculty of the Ohio State University for 13 years before coming to the Cayman Islands to join Jasmine as their new palliative care physician. Specializing in pulmonary, critical care, and palliative medicine, Dr. Goodman has the unique privilege of helping patients with a wide range of medical challenges. Her approach is tailored to each patient's needs, whether through aggressive critical care to aid in recovery from acute illness, or by managing pain and symptoms to improve the quality of life for those with incurable conditions. Dr. Goodman is passionate about helping patients and their families understand their medical conditions, honoring their wishes, and working with them to set realistic goals based on their health and personal values. Her focus is always on helping patients live better, whether through treatment or compassionate palliative care. And she is going to talk to us, she's going to tell us what she's going to talk about. So come on up, Dr. Goodman.
Thank you, everyone, for being here and for sticking with us past the break. It's been such an honor and a delight being here and getting to know folks in the community, and I look forward to getting to know all of you even better and working closely with you. I think our afternoon is shifting from sort of the high level, what is palliative care, why is it so important, how do we progress the field in areas where it hasn't taken hold quite as strongly as it needs to a more focus on individual symptoms and management. So I hope that this will be very helpful from a clinical standpoint. As Dr. Habde stated, I am guilty as charged of being both a hospice and palliative physician and a pulmonary critical care physician. For the moment I have hung up my critical care hat, 2 pandemics in one career, I think is enough. But really what I love about both fields and about internal medicine and about all of medicine in general is that opportunity to continue learning and to really take what we know and to what our colleagues know and what our colleagues in all the different disciplines see and understand and grasp about not just disease processes, but about how they affect each patient, and apply it so we can make life as good as it can be for each patient. And as an example of that, obviously dyspnea is a symptom that is near and dear to my heart, but not just mine. I think everyone has seen it in their patients. Everyone's seen how terrible it can be, how the fear of dyspnea can really impact people's lives. And so I hope to go through in the next 20 minutes, give or take, about a framework for thinking about it, and just some little pointers and some little reminders of ways of thinking about this really important symptom. So defining it, obviously shortness of breath, breathlessness, those aren't always the same thing. It can be a subjective sense of breathing discomfort, and it's distinct from respiratory distress. Respiratory distress being what we observe. We look at a patient who's breathing hard and we think they must be uncomfortable. But what's really been remarkable to me over my years of practice in all my fields is how someone looks isn't always, in terms of their work of breathing, in terms of their speed of breathing, isn't always how they feel. It's really quite amazing. And some descriptions that we'll often hear. Sometimes it's, I'm smothering. Sometimes it's, I'm working so hard to breathe. Sometimes it's, my breathing just stops, or I'm suffocating. And sometimes it's just, I can't stop thinking about my breathing. And this can be incredibly consuming and incredibly frightening. And so it's really an essential symptom to think about. What is the scope of this problem? Certainly numbers vary. In one study, up to 8.5% of A&E visits were for shortness of breath, primarily, up to 2.5% of primary care visits. And this can change through the years. It can change depending on the time of year. It can change depending on the environment and the location. But over 10% of palliative care consults in some studies are for shortness of breath, primarily. Remarkably, how many patients does this not impact? 42% of patients with advanced cancer in one study did not have shortness of breath. So really quite a majority do. And at the end of life, 90% nearly will have some form of shortness of breath, respiratory distress. So really, you will see this. We all will, and we all need to deal with it. I won't belabor all the systems that can be involved, but to summarize, it's all of them. Every single system we have can be a contributor towards or a direct cause of shortness of breath. And that includes the obvious ones, lungs, heart, airway, but also things like the vascular system, the neuromuscular system, the musculoskeletal system. The number of patients I've seen with restrictive lung disease simply because they had scoliosis or kyphosis is tremendous. We always have to think about intra-abdominal processes. We have to think about metabolic processes. One of the presenting symptoms of such a common process as diabetic ketoacidosis is that heavy, labored breathing as they're trying to compensate for the acid buildup in their blood. And then we also always have to think about the psychological aspects that can contribute to or simply cause shortness of breath. A really lovely and I think helpful framework for thinking about shortness of breath is that it's not all physical. So this biopsychosocial model, I think, is a really wonderful way of thinking about it. We think about what is the symptom. We think about, is the disease causing it modifiable? Is it curable? Is it treatable? If it is, then obviously we want to, as we've heard earlier today, obviously the mainstay of improving the shortness of breath is to treat that disease. But that's not the only thing that we do. While we're in the midst of treating a COPD exacerbation, we don't just focus on, well, we have to reduce the inflammation and airway obstruction. We think about, how do we help you feel better in the meantime, right? So, making sure that we're thinking about how do we help treat that symptom while we're treating the disease is really incredibly important. And I think we've heard over and over again today how that is really palliative care. And it's not just palliative specialists who do it, it's all of us. Everything we do is meant to help people feel better. It's not to, eradicate that Pseudomonas that's living in their lungs. We do it to make people feel better. If the disease is not modifiable, not treatable, not curable, then obviously we have to think much more about how do we help this person to feel more comfortable, to be able to do as much of what they want to do as they can, with the resources that we have available. And then with both pathways, we have to stop and think, how are we doing? We ask the patient, first and foremost, how are we doing controlling your shortness of breath? If we're doing well, wonderful. If things change and we need to do better, we go back to the drawing board if we need to keep thinking about how do we keep that symptom controlled. Another really nice mnemonic for things we need to think about in terms of not the exclusively physical, but for all potential causes of shortness of breath is this wonderful, brilliant mnemonic, dyspnea, which I absolutely love that they used the word for the mnemonic. But thinking about things like depression and sadness, if you have a really huge emotional blow and you're thinking about it, and sometimes, whether it's heaviness in your chest, whether it's just you've been sobbing and you're trying to catch your breath, all of that can lead to shortness of breath. Sometimes it's yearning for things to be different, for peace, for rest, sometimes for forgiveness. That's a complicated piece that it's hard to take the time to really think about, but it is so important to our patients and to their families. There can be social issues that cause internal stress, whether that's with the community, whether that's with family. Obviously, physical problems are the thing that certainly we as physicians are most trained to think about, but they're not the only piece. Non-acceptance and spiritual distress can be a big piece. Economic and financial distress is something that we always have to think about. It was very interesting listening to Dr. Medina's talk. The insurance situation here in the Cayman Islands is somewhat different from the system in the US, and I know it's very different from the system in the UK. And just no matter where you are, there are pluses and minuses of the system, but everywhere, I think, there's the potential for economic distress, whether it's the cost of treatment, whether it's the cost of yourself not being able to go back to work, or your family needing to take time off work to care for you. All of that can build up and cause shortness of breath and certainly other forms of distress as well. Anxiety is one of the I think, best known psychological forms, but we don't think about anger as much. And I think that's really interesting. In dealing with emotions, we don't have to be exactly right when we name the emotion when we're talking with families about what's going on and how they're feeling about it. But I think very often, unless they are screaming and raging and red-faced and slamming their hands down on the desk, sometimes thinking about anger is really important, and naming it and encouraging them, as long as you're expressing it in ways that are safe for you and for others, it's okay to feel angry. It's okay to feel cheated. It's okay to feel that all of this is incredibly unfair. No one deserves to be sick and suffering, and it's okay to feel anger. And then working on how do we help cope with that. Similar to systems involved is what specialties might we work with? There are the obvious ones: general practice, internal medicine and pediatrics, respirologists or pulmonologists, cardiologists, emergency physicians and urgent care. Critical care, obviously, is a very common one. Infectious diseases. I don't know that everyone thinks of neurology, but it is certainly a common one. We've got lots of ALS and other neurologic issues that will affect respiratory muscle strength. But really, everybody else can be involved. Some of the medical specialties that you might not think of as much, hematology and oncology, very frequent symptoms of all of the disease processes that they can treat. I don't know that we think so much of hepatology, but where I came from was a fairly large hepatology center and liver transplant center, and so you may think of hepatopulmonary syndrome as something you read about in a book once and forgot about, because whoever sees that seen it, and the shortness of breath that people get going from laying flat to sitting up really can happen. It's remarkable. Nephrology, similarly, fluid balance is incredibly important when it comes to breathing. Rheumatology and immunology, various forms of vasculitis and immune-mediated lung diseases. Really, we have to think about all of it. Otolaryngology. I know we had our friendly neighborhood head and neck surgeon here. She may have had to step out, but there are all sorts of disorders of the upper airway that can cause shortness of breath. And if we don't think about them, we miss them. I know I am a frequent suspector of even just vocal cord dysfunction, which can be episodic and really hard to catch if you don't think about it. OBGYN. It's funny because we think about pregnancy often as just this normal, natural process and just, isn't it wonderful? Here's a baby that's growing and everything should be roses and wonderful. It can be a really difficult process. So many changes happening in the person's body as this fetus, as this baby is growing, that can cause shortness of breath. And it's not necessarily even all physical either. The thoughts of, oh my goodness, I'm about to welcome this little person into my life. It's very exciting, but it can be really, really scary at times too. And then certainly, I don't want to leave our surgical colleagues out, because there's such a myriad of processes that can happen that either are related to things that they're treating, that can be side effects of the incredible work that they do, or that can be relieved by their expertise. And finally, physical medicine and rehab. I don't want to leave them out either, because they see these patients who've been affected, whether it's spinal cord injuries, whether it's various neurologic injuries. Really, they can do so much to help and to recognize these symptoms. And psychiatry. We've been talking repeatedly about the psychological symptoms and psychological processes that can manifest as shortness of breath. And if we don't really listen to our patients and really think about what is going on, why are they short of breath, we may miss some really important issues. So non-pharmacologic management, it's easiest, I think, to think about what medicines can be involved and what medicines can help. But I think it's really helpful to think about what are the non-pharmacologic means we have to help with shortness of breath. And you may be surprised by the simplicity of some of them. And these are evidence-based techniques. This is not, well, it might work, so let's try it. These are techniques that studies have been done and have shown real effect. Something as simple as a handheld fan. It's hard to believe, but multiple studies have been done and shown that something as simple as a handheld fan used to help shortness of breath really does work. For appropriate patients, pulmonary rehabilitation programs can help. These are structured exercise and counseling programs, typically about 3 days a week for several hours a day for a process of 8 to 12 weeks. I know that some insurances in the United States have limits to how much they will cover. I've not yet encountered how the insurance programs here in the Caymans cover them or don't, but really can be incredibly helpful in terms of endurance, in terms of the experience of dyspnea. So it's for appropriately selected patients can be incredibly helpful. Perhaps surprisingly to some, perhaps not, acupuncture has some evidence to suggest that it can help reduce shortness of breath. I will say I'm not as familiar with the specific sites, but you know, an acupuncturist who knows how to help manage this can, and there's data to show that this works, which is really wonderful. Biofeedback techniques, mindful breathing. I know very often sort of the basic level that we teach folks, especially with obstructive lung diseases, such as COPD and asthma, would be pursed lip breathing. And it's a technique where this also works as sort of the intro level for paroxysmal vocal fold dysfunction. You have the patient take in a breath through their nose, nice and slow. And then if they can hold it for a second or a few seconds, they do. And then to breathe out through pursed lips or breathe out through a straw and repeat that several times. And that can kind of help their mind reset, help their body reset. In the case of vocal fold dysfunction, there's some evidence that it actually helps to get the vocal cords moving in the proper direction again. And it's a fairly simple technique when you're not short of breath. Having patients practice it when they're not in distress is really important, because to take someone who is huffing and puffing and just really scared and feeling awful and tell them to slow down is not so easy if they haven't practiced it. Similarly, there is a technique that is used in some militaries and I think by a lot of people around the world called tactical breathing or square breathing. And essentially, you take your breathing and you think of it as a square. You take your breath in and you pause, you breathe out and you pause. And again, it's hard to do when you're feeling acutely short of breath, so practicing ahead of time is really important. But it can help to slow down the breathing. It gives them something to focus on other than, I feel awful. And it gives them the sense of control. And sometimes that can help to get things back under control. Positive airway pressure is another non-medicine form of help, particularly for folks with chronic hypercapnic respiratory failure. Having nighttime positive airway pressure has been shown to help reduce exacerbations and help to just sort of give them a running head start during the day. If they can rest their breathing muscles at night, sometimes they can have more energy and do better with activities during the day. Oxygen. So this is probably the one thing that everyone thinks of first and foremost when thinking about shortness of breath. If I'm short of breath, I must need more oxygen, right? Yeah, not always the case. There are studies that show that high flow oxygen can help with the shortness of breath that happens with exercise. Fascinatingly, low flow oxygen has been shown to be equal to just medical air. So it's not the oxygen itself, it's the airflow. And I think this really supports why do handheld fans work. And also fascinating, it doesn't seem to matter if the patient is hypoxemic or not. It doesn't seem to matter if you would expect, I think, for a patient with normal oxygen levels, if they're short of breath and you put them on oxygen, is it gonna help? Maybe, maybe not. For a patient whose oxygen levels are low, it doesn't necessarily help any more than medical air. It's a really interesting phenomenon. And some of that depends on how quickly they've become hypoxemic. For those who've been sort of creeping down over years, some of the patients I've seen with COPD or with interstitial lung diseases, if they're used to getting down to 70% every time they stand up from a chair, they may not notice a big change if you get them up to 90%. And others will. It's a fascinating process. One other interesting piece is that studies have shown, and this is a preview of what's coming, that oxygen is not superior to opioids for control of dyspnea. And what really fascinates me is people's attitudes towards oxygen. It can be a really powerful symbol of medical care, and people can really get attached to it and really think, I need this, I'm dependent on it, it's a 100% good thing. Others really are fearful. Particularly, I've found people with chronic lung disease who have not yet shown requirement for oxygen and start to. Sometimes they're very accepting and say, yes, I think this will help me, so I want to start it. Sometimes that stigma of, if I'm needing oxygen, it means I'm sick. It means I'm getting worse. So it's really important, if we're talking about starting oxygen for our patients, to explore, what does that mean to you? What do you think this will do for you? What are your worries about it? The other thing that I don't think we ever really talk about is the side effects of oxygen therapy. I think first and foremost is that nosebleeds are actually a fairly common side effect. Usually they're not severe. Sometimes they can be. Sometimes they can get to the point of needing embolizations and that sort of thing. So it's not an entirely benign process. The other piece is, theoretically, people who retain carbon dioxide can depend on their hypoxic drive to keep breathing. I'll say I've maybe seen it once or twice where I thought someone's breathing was suppressed by oxygen. It's pretty widely debated, but just to remember that oxygen is not necessarily a purely positive thing. Thinking more in terms of medications, there's been a lot of discussion over the years about inhaled medicines. And for years, there was a lot of hope. Do nebulized opioids help? I think the hope being that we would reduce systemic side effects and improve just treatment of dyspnea with them. There's one small study that shows that maybe they do help. The coughing spell, able to break the vocal cord dysfunction for long enough that they were able to recover and escape that. So I have to admit I am a fan of this treatment in the right setting. And finally, opioids. We think, or not quite finally, but opioids are obviously what we think of when we think of palliative care, when we think of hospice, and it's for good reason. There are lots of studies showing that both parenteral and oral opioids have great evidence for effectiveness. One thing that I hadn't known as well, where I trained and where I worked, it very much was the case that short-acting opioids were the mainstay of what we did. And as I think about it, that was almost whether the patient had continuous shortness of breath or intermittent. In reviewing studies, though, there have been several where sustained release morphine has been used, and it's with a number needed to treat of 1.5 patients. I don't know that I've ever seen another study in any other treatment where you can treat so few patients and have good effect. And the doses needed are typically quite low. 70% of patients in one study were able to benefit from just 10 milligrams a day of sustained release morphine. So when we look at the enormity of average doses lifetime that people are getting in some countries, that isn't what's needed typically for shortness of breath. It's very small. We talk a little bit about the principle of double effect. For those not familiar, it is the thought that if you give a medicine that could shorten someone's life or cause their death or hasten it, is that acceptable? And the thought is, if you're giving it with the intent of relieving a symptom, it's acceptable. I will say that multiple studies, and certainly my experience, I suspect everyone else's as well, are that as long as you're thoughtful about your dosing and your dosing intervals, opioids really do not hasten death. They do not suppress respirations as long as you're careful. They don't impair cognition, and these are in multiple studies, not just personal experience. And they don't accelerate time to death. We'll all hear those stories of, oh, my so-and-so took a dose of morphine and then they died. So it must have been the morphine that killed them. We've all heard that probably, right? It's not the morphine that kills them, it's not the opioid that kills them. We give the medicine because they are having symptoms while they are dying. It is the dying process that is killing them. It is the disease that is killing them. Sometimes there's a temporal association, and that's always hard, but it is generally not the opioid that does it. Similarly, benzodiazepines are more of a mixed picture. Several of members of the class have not been shown to be any better than placebo. In combination with an opioid, they may be helpful. And there was one study that showed that oral midazolam may be a little bit better than morphine in certain populations. And finally, on more of the palliative side, thinking about not just medicines, not just the more integrative processes, but there are sometimes procedures that, while invasive, can be really helpful, that I think it's important for us to keep in mind. We had a significant population of patients with COPD who would come in for what we call lung volume reduction surgery. And it sounds, if you haven't seen it, it sounds really a little disturbing. You take a patient who's having trouble breathing, whose lungs are diseased, you cut out a piece of their lung, and they're supposed to breathe better. But if you're very selective about the piece of lung that you take out and the patient in whom you do it, you can improve their shortness of breath, you can improve their exercise tolerance, you can improve their oxygen needs, and you can even improve their survival. So this is really a wonderful example of a palliative procedure that is also life-sustaining. And having seen a number of these patients come into the hospital on oxygen and walk out without it, it's really a remarkable process. Similarly, thinking about things like malignant pleural effusion, placing indwelling pleural catheters for recurrent drainage, or performing talc pleurodesis. There's some evidence that talc pleurodesis, if it takes, may be more cost-effective and more effective. I will say, I don't know that I've seen it work as often in my own experience, but both are really important considerations. And then certainly for patients with central airway obstruction, sometimes our interventional pulmonary colleagues can perform place stents and things like that to help with shortness of breath. And in closing, I'd like to leave with this very lovely framework for thinking about shortness of breath. There's a number of different scales that we can use for measuring the severity. When it's mild, obviously asking, or really all the way through, asking about psychosocial and spiritual and emotional distress is really important. The fan, again, even when it's cold, even up in Ohio, the fan can be helpful, but certainly here, very helpful. Repositioning, because if we think about it, how much of our breathing is affected by how we're sitting, how we're laying. Just really simple and important things to think about. If they're hypoxemic and supplemental oxygen helps them feel better, wonderful. If it doesn't help, depending on what their goals of care are, don't worry about it. And then moving up to short-acting opioids, longer-acting opioids. And occasionally we have to think about things like palliative sedation. But I hope that this has been a helpful, brief review, just to have us thinking about sort of the really comprehensivist approach to symptoms and dyspnea in particular. And I'll welcome any questions. And again, thank you all for being here, and thank you for your time. I think also given the time, I will be happy to take questions later on as well, so I don't make us later than I intended to, but thank you.
Thanks so much, Dr. Goodman. It is a common symptom, a scary symptom. So I think that was very all-encompassing and give us all something to think about, things that we don't always think about. So we're now going to ask Dr. Mark Stoltenberg to come back. I've already introduced him, so I won't go through it again. But he's going to talk to us about ethics and the withdrawal of care.
Okay. I know we're after lunch and we're about 40 minutes in. How's everybody feeling? Should we do a quick stand up and just do one of these? No? Okay, everyone's fine. Very good. Okay, so I'm excited to be able to spend another 30 minutes with you talking about another topic, thinking a little bit about ethics around how we think about palliative care and the things we do or sometimes don't do and how we think about that within the lens of benefits and burdens. So what we're going to cover for this next session is first review the history of bioethics a little bit, but mostly focusing on principalism and casuistry and how they both really have an important role as we think about thinking about challenging ethical things that we might face in palliative care. Then we'll move to try to consider the four-principle model of bioethics. We'll talk about those four in a moment. And then finally apply these models to a common ethical challenge of withholding and withdrawing medical interventions near the end of life. And then hopefully have a little time for a discussion around it near the end. So, ethical principle of palliative care. So first, I don't know if folks here have been to lots of palliative care conferences. Have you noticed we always talk about ethics? I mean, granted, ethics is of course important in all medical care, but it seems to come up a lot in palliative care. So I think that's for a couple of different reasons. So one, ethical conflicts are really, really common near the end of life. One, because it's a very high stress, high emotions moment. It's a challenging time for patients and their families. And the other piece is a lot of our standard protocols and ways of thinking about ethics in your typical patient, pediatric patient, or your typical patient treating something serious, but we expect them to go on and get better. When we start to get to the limits of what medicine can accomplish and what we can expect as far as the benefits and burdens of what we're doing, the context shifts a little bit. All the rules stay the same, but the context shifts a little bit, so it can take sort of a refresher and a primer to think about, oh, how do these same principles now apply in this very different setting when a patient is maybe days or weeks away, and then certainly in their final hours of life. So I think that's why it's important. The other piece, so we already had a wonderful session on communication in palliative care. I think it's really important to learn those skills. And often when it comes time to give the headline, when it comes time to ask about preferences, having really clear ethical language, so how we think about the ethics and then interpret that in very sort of common, easy to describe ways to patients and families is really important. So for me, the communication skills and the ethics actually go really tightly together. When we do our advanced training course that we teach in Chile every year, we actually have an ethics session before each communication session to make sure the ethical parameters around the issue we're talking about are clear first before we move on to trying to teach the communication skills. So I think they're very, very tightly connected. So medical ethics, folks have probably seen this before. In general, it's leaning on values and moral principles that help us make judgments in medical care. Medical ethics, it's also interesting just to think about where it came from in palliative care. So really was birthed after World War II in the 50s and 60s and 70s. Certainly thinking about what we should and shouldn't do is as old as the Hippocratic Oath, but it got a lot more complicated when our technologies became so much more advanced. So as we had these new technologies, thinking about, well, how do we distribute them equally? How do we think about when they apply? How do we think about a concept like medical futility, which was not something that we had to think about quite as much before we had all these technologies? It really changed the framework, and medical ethics really grew out of that. Palliative care grew around the same time and often in parallel. So oftentimes when you're thinking about an ethics committee, in our hospital, so I'm on our hospital's ethics committee and I'm on the palliative care team, I often say for most ethical things, get palliative care first, and if we can find a way to move forward that it doesn't get more complicated, great, and then if we're really, really stuck, we then call in the ethics committee. But just to name, ethics and palliative care is very, very tightly connected. And then at the end of the day, I think a really important thing to name is in general, ethics gives us a framework for how to think about cases it's not quick, simple solutions. It wouldn't be an ethical problem if it had a simple answer. The reason folks are coming to you on an ethics committee with an ethical problem is there's a lot of layers to it, and so we need frameworks in order to communicate with each other, but it still takes conversation and listening to be able to get to a consensus perspective. So knowing it's not just quick answers the way some other parts of medicine might be, it's complicated for a reason. So this is one piece I find really, really important and interesting as we start to think about how we're going to navigate through ethical challenges. So there's one way, so there's a lot of different frameworks that we could apply for ethics and how to think about right and wrong when we're caring for our patients. Two sort of very common threads that are a bit in competition, but I actually think they go really, really nicely together. So the first is principlism. That will be ultimately a bit of what we're going to do today. So there's the 4-principle model, which is the most common one, which we will use today. There are other core principles. The idea is you start from the principle, the core concept, the theory, and then you try to think through, well, how does that apply to my case? Very important. Any good ethicist will need to be able to do this, know what those principles are. And I will say, and there's a beautiful, in the most recent edition of the authors of the 4-principle method, they have this wonderful paragraph describing the balance between these two things that I'll read for you in a moment. The other side of the coin is something called casuistry. The folks maybe have heard of the Jesuits. They were very famous for doing this from the Catholic tradition. The idea is instead of starting from the principle, you actually start with the case in front of you, and you think through what are other cases that are similar, so you start from the particular, from the specific story of this patient and this family and this disease at this time in this country with this particular resources that might be able to help. And you start from there. What I find really beautiful about this is I think casuistry is deeply connected to palliative care. When we talk about suffering, what do we say? It's whatever the patient says it is. We start from the view and the perspective of the patient, and then we move towards principles. So any really good ethicist will tell you, you need to be able to do both. If you only are listening to the case, but you have no principles to connect it to, it can get hard to know how to navigate through the dilemma. But I think it's really important, and I would say some of the not quite as effective ethicists that I've worked with are the ones that are too rooted in the principlism, and when sometimes the case just doesn't quite line up, they can't put the principles to the side and just hear the patient and listen to what the patient and the family are saying. So I think as we think through these cases, both sides are important. We need to know the principles, but always at the end of the day, trust your gut, and if something in your gut's saying, but this just doesn't feel right, there's a reason for that, and let the complexity be a part of the case, and always listen to your patients. That's always what comes first. So with that sort of disclaimer about how we think about ethics, the 4 core principles of medical ethics. I already threw them up there, but do folks feel like that feels familiar? Have they seen them before? Does anybody want to really help me out and shout out one of the 4? A little louder. Non-maleficence. Autonomy. Justice. And beneficence. Oh, A+. Best audience I've had in a while. Excellent. So these are the 4 core principles. Not the only principles in healthcare. Things like dignity, compassion absolutely matter. And it is one of the most sort of time-tested ways of analyzing most of the challenging cases we run into and are quite effective at helping us navigate through. So not the only way to look at, but I think are very helpful, and we will lean on this as we start to think about our individual cases today. So what are these 4? Folks are probably familiar, but just to clarify, so autonomy, does the patient understand the risks and benefits of the intervention, and do they want it? Heavily relates to capacity. Are they able to think through the risks and benefits? Also thinking about, well, who's making the decision when we think about surrogacy and some of the things that were spoken about earlier today. So that's a brief summary of what we think about when we're thinking about autonomy. Beneficence, easy. Do we think that this will help the patient? Will this lead to either living longer or living better, decreasing suffering or increasing quality of life for this patient? Non-maleficence, do we think that this will cause harm? We're going to talk a little bit more about how these are often connected, and specifically in some of the cases that we're going to go forward. So do we think that this is going to cause harm to the patient and or the family? And then the final question is justice. Is this a fair utilization of resources? We do not have enough ICU beds to treat every single patient, or we do not have enough palliative care specialists that every patient in the country gets a daily visit from a palliative care specialist. So we have to think, how are we going to distribute these resources? And I will just say, at least in the US healthcare setting, this is the one that gets the least amount of attention. We focus a lot on the other 3, and justice is often the forgotten one in the background. I think globally we need to do a much better job of making sure justice stays a part of the conversation and not just the other 3. But these are the 4, and I think can be really, really helpful. So as we're thinking about this, oh, great, we have these 4 principles. Easy. I just apply these, and I'll know what to do. What's the problem with this model? What's the challenge? There's probably plenty, but there's one fundamental shortcoming or challenge when we try to apply 4 principles to a particular conflict or issue. So the key issue is, which one wins? If you have one in conflict with the other one, who decides which one's more important? So almost any ethical conundrum that you run into in healthcare, and very much so within palliative care, comes down to 1 or 2, 3, or 4 of these coming into conflict with each other. So the key piece, as I was saying at the beginning, this is not meant to, oh, I have this case, easy. I just throw these together and I have an answer already. No, it gives us a framework to explain what's at stake. A framework to say, oh, where is this conflict coming from? The daughter is thinking about beneficence, but the son is thinking about the non-maleficence and is worried about the harm that it might cause. And the doctor's worried about autonomy because the patient's voice needs to be involved in deciding what to do. So this gives us a language to discuss what the conflict is, and then ideally helping the group come towards consensus by using that language. So the core challenge when we run into any ethical issue, and if we were doing a whole afternoon on ethics, each case we would start with which 4 are involved, what are in conflict, and what are all the parties involved, and how do they connect with these 4 principles. Does that make sense? So at the end of the day, most of the things we run into are usually a combination of at least 2, but sometimes 3 and even 4 of these that are coming into competition. So I think the last part then, do any folks know this sort of allegory of the elephant? So these are a bunch of blind men, all at a different point on where the elephant is, and they're all touching it, and they're all trying to decide what this is. So the blind man in the back says, oh, elephant, yeah, it feels like a rope. Elephants are ropes. He's not wrong. It's just he only has the tail. That's all he can see with his perspective. The person in the front feeling the ear is like, what? It's not a rope at all. It feels much more like a nice, big, soft blanket. Are they wrong? No. From their perspective, that's the principle they're looking at. That's the experience they're having. And so if ultimately we approach this of saying, oh, there's clearly one right answer here, we're going to be in trouble. So when it comes to ethics in the experience of others, we are all blind men, blind people, entering into this, and we have to then listen to the experience of others, see what principles they're talking about, and then that can give us a language to hopefully have a way to talk through it. So really core skills that are necessary is a sense of curiosity. Oh, tell me more about your perspective and how you're seeing this case. When the son comes from out of town and says, you have to do this for mom, tell me more about it. How has your relationship been like with your mom? Did you have conversations with her before about what she might want? Tell me about those. So approaching with a bit of curiosity. Empathy, knowing at the end of the day, everyone's doing it for a reason. In general, family members are not trying to harm each other. They might misunderstand what the other one wants, but they're all coming from a place of good faith. So applying that empathy to everybody involved will get us a long ways. The last piece that's important to recognize is self-awareness. When people say to you, oh, I'm entering into this, but I'm objective, I'm not going to have an opinion, they're lying. Not possible. We're talking about end-of-life issues. We all have a perspective. The goal is not to pretend like you don't have one. Your goal is to take time to reflect and know what yours is, to be able to say, ooh, I'm about to go into this issue. I know I have a complicated relationship with my mom. This is going to trigger me a little bit. So I need to be extra careful when they're talking about their relationship and adapt for my perspective. Do my best so it doesn't impact what I do. Of course, how my relationship with my mom should not be affecting my patient, but I can't be objective. I have to know what my perspective is first, be prepared that some things will be easier or hard for me, and then enter into the conversation. So self-awareness is really, really important. So as I noted, so these are the founders of the 4-principle method. They wrote it back in the 1970s, but this is only in their most recent edition. So in 2020, and they talk about medical ethics, not just in palliative care, but across medicine, but they specifically were talking about palliative care, and this one I will actually read. So they said, principles and rules cannot fully encompass what occurs when physicians and nurses provide palliative care for a dying patient and comfort to the patient's distressed spouse. Our feelings and concerns for others lead us to actions that can't be reduced to the following of principles and rules. We all recognize that morality would be a cold and uninspiring practice without varied traits of character, emotional response, and ideals that reach beyond principles and rules. They understand you have to do both, and they're the founders of the principles. So you need the casuistry too. You need to listen to who the patient is in front of you while you're thinking about those principles. Okay, so now I want to move from that initial theory and try to apply it to a particular case. So we're going to introduce ourselves to Jack. Hypothetical patient, but I'm sure many of us have seen patients very, very similar. So he's a 60-year-old man with a long history of metastatic colon cancer that has been steadily worsening for the past 6 months. And he was just admitted to the hospital 2 weeks ago for worsening cachexia, poor appetite, and abdominal pain. The patient now appears exhausted and uncomfortable. The team, the medical team, is wondering about the ongoing use of artificial nutrition and hydration, but they're also unsure if providing or withholding these interventions would be ethical or the right thing to do for this patient. So, thinking back on our 4, and we can have a brief discussion or we can just raise our hands. Which of our 4 ethical principles are in conflict? So, who says justice is involved here? Yeah, could be a little bit. In general, most of these cases, it's all 4 to some degree. Who says beneficence? So the intention to help is involved. I'll help you. Non-maleficence, a worry about causing harm and wanting to be thoughtful about will this harm? Yeah, absolutely. And autonomy. Exactly. So certainly, I think there's ways, and in certain settings, this could be justice, but absolutely autonomy, beneficence, and non-maleficence are all absolutely in this issue. So we'll try to piece this apart a little bit. So one of the key principles when you think about ethics in palliative care is that typically, and especially as patients are approaching the end of life, beneficence and now non-maleficence become linked. What I mean by that is almost all the interventions that we do in healthcare come with both. I'm very pro-vaccine. My kids are vaccinated. I hate taking them to get their vaccines. They scream. It hurts. If anyone wants to tell me, oh, vaccines don't cause harm, come and take my kids to get their vaccines. They absolutely, my son tries to run out the door. I have to hold them down still. They hurt, but the benefit far outweighs the burden when it comes to their routine pediatric vaccines. So of course we do it and we don't debate it and it's fine. It's a part of life. Now, there are other interventions, so things like chemotherapy. It's a new diagnosis and it's a cancer that's expected has an 80% response rate to first-line chemo. Do we recommend it? Absolutely. Does it also cause harm? Absolutely. They're going to be nauseous. They might get a little weight loss. They're going to feel terrible for a day or two afterwards. So it causes harm, but the benefit is so much bigger than the harm early on in their diagnosis for particular cancers that almost always we do it. So the challenge is in healthcare, we don't think how these are linked because the majority of healthcare in non-palliative care settings, the benefits are so much greater than the burdens, we pretend like the burdens don't exist. Every lab draw we do hurts. I'm not saying don't do it anymore. Of course, laying flat for a CT scan. Has anyone ever had to do that? It hurts. It's a really uncomfortable board. If you have bone pain and you have cancer in your bones and you're asked to lay flat, that is not a benign thing. It hurts. So when we think about things as we now near the end of life, it can be where things start to tip the other direction. So if it's not going to meaningfully change my plan to care for you, or I actually think you're in the final hours of life and there is no chance it can benefit you, if I put you through harm, I am choosing to hurt you, knowing in my head there is no chance of help. Is that ethical? No, of course not. So when we're in palliative care settings and we were thinking about any intervention we would do, we need to be thoughtful about every single intervention. Early on, my kids in the doctor's office getting their vaccines, the benefit is so much bigger, I just say tough and we're going to the doctor because you need your vaccines. No debate in this house. Later on in life, there are a lot of things that we should not be doing to our patients. Chemotherapy, when it's 4th or 5th line and there's a 5% chance that it's maybe going to help a little bit, but the patient is clearly dying in the next few days, any oncologist will tell you that is inappropriate care. They should not even be offering chemotherapy in that setting. Now, where the decisions are hard was a month earlier than that. 2 months before we think they might die, 40% chance it might help, but 60% chance they're going to get really sick. Then it gets a little harder. Patients' values and goals play in. I'm not saying those are easy decisions, but that's where the hard decisions come in. But what we need to recognize, and we're going to now move to some of those interventions that we might withhold or withdraw, there comes a time where every single thing we're doing to patients is the chance of harming them is greater than helping them. And anytime there is it is significantly clear that it's going to harm more than help, we should not be offering it because it is unethical to do it, because we are harming them. So we'll now try to apply this way of thinking about how these two things are in conflict back to our case. So after weighing the benefits and burdens of his treatment option together with the family, you decide to focus on Jack's comfort, because it is clear Jack is in the final weeks to maybe days of his cancer journey. So you decide that you're not going to place an NG tube because feeding him at this point would be unethical, because the likelihood he could absorb the nutrition and it could have a meaningfully positive impact on his care for this patient at this point in time, it is much more likely to cause him to have nausea, to cause him to have abdominal pain, and it's not going to meaningfully help him given the stage of his cancer, so it would cause too much harm, so it's not even an option that we would think about. Decide to decrease his IV fluids down to 10 cc an hour to make sure that his line can stay open, and you start to focus on his comfort by providing morphine. Now we're running into another challenge. So you are giving him a little bit of oral morphine. He says his pain is improving slightly, but he's still in moderate to severe pain when he's awake. And so you suggest on rounds that morning, together with Jack and the family, that it looks like we need to go up on the dose a little bit because he is still not comfortable. And the family is concerned because they said, no, but this is going to be killing him. Isn't this euthanasia if we give him higher doses of morphine and he dies in the next few days? How do we respond? So again, we pause, we have curiosity, we have empathy, and we think about our own perspective. Why are they saying that? Is it because they want him to suffer? Of course not. They also don't want him to die, and they're scared. And that's perfectly okay, and we can sit with them in that. And so we can emphasize, we completely hear the non-maleficence, we can hear that you don't want to harm him, and can we explain why we don't think this is going to have any impact on how long he's alive, and it's not going to make him die faster? And can we help talk to you about the beneficence we're thinking about? You wouldn't use those words, I'm helping connect us to the theory of why I think a little higher dose of morphine is going to help him so he can be at peace and have a dignified final hours to days or whatever time he has left. So we use our principles, but we also bring back our curiosity and our empathy. So when we think, and this was briefly mentioned in the great session, sorry, you're right there in front of me, about dyspnea, is this principle of double effect. So ultimately, double effect is just beneficence and non-maleficence when one single intervention has both intertwined. So when there is an intervention that we believe will provide benefit, but we also know that it is likely to bring some sort of harm, it is ethically okay to do so, so long as we think the benefit is greater than the harm. If there's any intervention we do that think the harm will be greater than the benefit, that would not be an ethical thing to do, and we would not do it. The key piece is the intention is the benefit that we think will be greater. So are we giving more morphine so he dies faster? Absolutely not. In any setting that you're doing that, that is not appropriate. That is not ethical care. Are we providing morphine to make sure he's comfortable, knowing that he might die? And in some settings, they might die a little faster because we're helping them be comfortable. But the intention is never to hasten their death. It's to maximize their comfort with the time they have. That is an ethical thing under the rule of double effect, which is a very ancient principle that's been around for thousands of years. So again, if the benefit of a particular intervention, if it has a benefit and a burden connected to it, most medications do, they all have side effects. If the benefit is greater than the burden, it is ethical by virtue of double effect, and it is reasonable to do for that patient. So this also applies when we think about either withdrawing or withholding interventions. So withholding an intervention, a patient with COPD who's really nearing the end of their life and a choice to intubate them or not intubate them. If we're at the point where we think the burden of doing something outweighs the benefit, it is ethically permissible to not offer that intervention. An easier example would be a cancer patient who looks like in their final days or hours of life and offering chemotherapy because the family says they want everything. They would be ethically permissible and correct to not give that patient chemotherapy because even though they want everything, the likelihood it's going to burden and actually make them die faster and in more pain than benefit is so much greater, it would not be ethical to offer that patient chemotherapy. It also applies with withdrawing treatments. So we can think about that COPD example. Sometimes at a certain point in time, we think the potential benefits are here and the burdens are here, ethically reasonable to do a time-limited trial of that intervention. But now over time, it's 2 weeks later, and they started to shift like this. And we're now to a point where it looks like there is no possibility that they're going to get off the vent because they remain intubated. It could come time to say, look, it made sense 2 weeks ago. Now we're in a different place. and the settings are different, and the burdens are now outweighing the benefits, and we need to talk about a plan or an option for how we're going to extubate your mother or patient. So withdrawing treatment, it's the same principles. Things can change over time, and it's always a matter of the benefit versus the burden, just knowing that that can change over time. So I think some really common examples of applying all of these things. So we talked about artificial nutrition and hydration. So a really common one can be using IV fluids nearing the end of life. There are some places, cancer centers, that in general, as a rule, they start by giving very low dose IV fluids and they continue it until it starts to cause harm. Perfectly reasonable. In our setting, just happens to be sort of culture we're at. In general, we don't do it, but if there's an indication to do it, then we do, and we stop it when it starts to hurt. So IV fluids, on average, near the very end of life, we worry about the side effects, so eventually we know it's going to cause worsening pain, it's going to cause worsening shortness of breath, and it won't help you live longer. I have one case very recently. It was a Colombian patient that we had in Boston. Desperately wanted to hold on until his son could come from Colombia. 2 kids had already come to visit, so we continued the IV fluids. They were at 20 cc an hour. He was doing okay for a while, but then started to get worsening shortness of breath and worsening pain, but he really just had 3 more days to hold on. We decreased it to 15 an hour, and we kept trying to titrate it, but then finally he was just feeling so overwhelmed and short of breath because the fluid wasn't going where it needed to, that he said to me, "I'm done, I can't hold on anymore." And we stopped the IV fluids, and he died about a day later. It was an ongoing careful titration of benefits and burdens and having an honest conversation of it might help initially, but eventually it's going to start hurting, and there's going to come a time we have to stop it. A clear example with IV fluids. Chemotherapy, many oncologists will tell you that is one of the hardest decisions they make. When is the time where it's now going to hurt more than help? The study that I had mentioned before, the randomized controlled trial at Mass General, if you ask the oncologists that were involved in that study, they'll tell you the reason the palliative care patients that got it early on lived longer is because they made that decision better. They chose to stop chemotherapy at the right time. All the patients got chemo initially. It doesn't mean chemo's bad. It's just you don't want to give it when you're nearing the end of life because it's more likely to hurt than help. But when it tips from more likely to help hurt or more hurt help, by having palliative care involved and patients thinking about their goals and values and preparing for the end of life, they made that choice more accurately and therefore stopped chemo when it would have hurt them more than helping, and they ended up living longer. So chemotherapy is another really good example. Can also apply it to intubation, cardiac resuscitation. We're not going to go into that right now. So finally, a case conclusion for this. So after reviewing Jack's current status and expected course, you and his family agree to steadily increase the morphine only until he's able to be a bit more comfortable, not with an intention of making him sleepy, but knowing we're not going to stop until we get a dose where he can be comfortable. The goal is for him to be wakeful if possible and to have a little bit more time with his friends and family, but you also discussed he's probably going to get sleepy over the coming days, both a combination from the side effects from the opioids, but also the worsening of his underlying condition. And ultimately, his family was deeply sad that they were now recognizing that Jack was dying, but at the end, they also said how deeply grateful they were by the compassion and the empathy and the open communication that you have, and that they had the opportunity to know what was coming so they could sit with Jack in his final hours and days of life. So just to sort of bring home some of the core things that we talked about. So the 4 principles: beneficence, non-maleficence, autonomy, and justice. The challenge is when these things come in conflict, which they inevitably do. When they do, we want to pause. We want to make sure we have a sense of curiosity for everybody involved in the case. Empathy, no one's there trying to be a bad guy or hurt. They're all bringing their own emotions to this and trying to care for the patient and the family member as best they can. And some self-awareness that we bring our own biases and perspectives to this. That's okay. That's why we need to know what they are. And then ultimately, we recognize that typically the comparison of withdrawing and withholding interventions comes down to balancing benefits and burdens. So that is often the most important 2 principles that are in conflict. And that finally, these principles are only guideposts, as the authors of the principles said. At the end of the day, you need to listen to your patients and listen to your own heart, and that will help guide you what the right thing is to do. The last thing that I'll say about this, and this has been a really fun and interesting experience for me. So sometimes ethical care will actually be countercultural. So what we talked about this morning and we've been discussing, so palliative care looks different depending on what country and what culture you're in, how they think about autonomy, what the most common way of making decisions, how religion plays into it is absolutely different, and there are many different beautiful ways that communities come together to care. So there is an immense diversity in palliative care. And sometimes, I have practiced in many different parts of the world, there is still a perspective, well, the doctor knows best. The way to care for suffering is to be unapologetically, we cannot care for you unless we're interdisciplinary. So I hear you, that's how it's done in Rwanda, and can we talk a little bit more about it? I apply my own curiosity and empathy to that person, but also recognize good palliative care always has to be interdisciplinary, and good palliative care has to integrate the perspective of the entire family. So always being culturally humble where we are, and also recognizing there are some intrinsic values to palliative care that sometimes we need to be humble and also be clear that there is no future where we're going to care for patients well unless we are an interdisciplinary team that is caring for both the patient and their entire family. So with that, I will end, and if there's any questions, I'm happy to take them. Thanks so much. No, I think we're good.
Okay, thanks, Dr. Stoltenberg. Very valid examples there, which we face on a fairly regular basis. So our next presenter is Dr. Smita Almeida. She is going to talk about pain management in palliative care, an awareness, a skill, a necessity. An anaesthetist for the last 18 years, with a passion towards enhancing the perioperative journey of a high-risk surgical patient. Dr. Almeida completed her MD in anesthesia at St. John's National Academy of Health Sciences in Bengaluru in India. Her journey as an anaesthetist brought her to Cayman, where she served as a consultant at Health City, a major tertiary referral center, not just for Cayman, but also for the wider Caribbean. The immense advantage in surgical outcomes given by regional anesthesia urged her to delve further into advanced pain management, which she pursued by doing a fellowship in advanced pain management at the Royal Marsden NHS Foundation Trust in London, a premier cancer centre in the UK. As of August of this year, Dr. Almeida joined HSA as a pain specialist anaesthetist, and we're very happy to have her here. She's been a huge supporter of palliative care and Jasmine. Welcome, Dr. Almeida.
Thank you, Dr. Ginny, for the introduction, and thank you for the opportunity that Jasmine has provided me to speak about something which is very close to my heart. As Dr. Hobday has rightfully said, pain management is something that I pursued recently, but it's been very close to me, from the start. So I'm here to speak about something, create an awareness about pain management and provide my listeners with a skill which is necessary to alleviate suffering and improve the quality of life of patients in general and palliative care patients in particular. I have no disclosures, no conflicts of interest, and I'm hugely indebted to Dr. Janet Abraham's book, who through her book has given in so many clinical scenarios, few of which I will present today in my talk. So, originating from the Latin word for punishment, namely peona, and being part of some cliches like no pain, no gain, pain has both angered and intrigued people from time immemorial. But why an entire talk devoted to assessing and treating pain? Aren't we as clinicians and healthcare providers already in a position to, know something about pain management? We know that patients do need pain management. We know that they need to be referred to specialties which need pain management if we can't manage them ourselves. We do, but many times we realize that we don't know enough. And I can provide some examples for this. I shall quote some appalling statistics. In a study done by Van den Buchan et al. In 2016, it was noted that 55% of patients receiving cancer treatment and 66.4% of patients with advanced cancer continue to suffer from moderate to severe pain and don't get the requisite treatment. In 2017, the Lancet Commission on the Global Access to Pain, Palliative Care and Pain Relief, that has been quoted by some speakers in this forum, increased the number of symptoms that were included in the umbrella of palliative care to 16 symptoms. But the first symptom that came into their forum was pain. It has been there from the start of the number of symptoms that they've counted. So pain, and you'll all agree with me that pain is something, and is one of the first and foremost symptoms that brings the patient to the doctor in the first place. And that's what brings and then sometimes alerts them to the presence of a disease, and for which they just come for a consultation. We as anesthetists and as pain specialists are indebted to Melzick and Wall because they brought about this gate control theory to explain how pain, to explain the pain mechanisms at the spinal level. And we're also indebted to Dr. John Bonica, who was called a masked marvel because he literally wrestled his way into medical school in order to pay his fees. And he was so much, he understood very early that there was inadequacy in the recognition and the treatment of pain. So he founded the International Association for the Study of Pain, and he, as a founding member, advocated research into the treatment, into understanding the mechanisms, and thereby getting in effective treatment strategies. Pain has been included as the fifth vital sign, and this is for all of us to remember that when we record patients' pulse rate, when we record the temperature, respiratory rate, oxygenation, we do need to ask patients about whether they're in pain, and if they are in pain, I mean, how do we score it? I'll come to that later, but please do remember that needs to be recorded, okay? The Montreal Convention in September 2010 brought it out to the world. Access to pain management is a basic human right. So a topic as important as this is not understood well enough. And why is that so? Because though the International Association for the Study of Pain has been advocating for research, we've understood quite a bit about pain, but we haven't understood everything. They redefined pain in 2021 as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Now, every word of this is important because it's not just a sensory phenomenon. Pain is also an emotional experience. They included 6 key notes. I won't go into each of them, but one of them stands apart. And that's the note that a person's report of pain, of an experience as pain, should be respected. In other words, pain is what the patient tells you what it is, okay? This may be a little difficult for people to understand because we have some preconceived notions about how painful something is supposed to be, and when we do come across a patient who tells us otherwise, it's very common for people to brush it away as like, I don't think it's supposed to be as painful as you're describing it. That's what's going on in a mind, though we might not say that to the patient. But why is it that different people with similar kind of pain experiences experience pain differently? So let's revisit our understanding of pain, okay? All of us understand that when our body is exposed to a noxious stimulus, like for example, you're pricked by a pin, or step on something sharp, or you happen to touch your arm to the oven while taking out a dish from the oven, there is a stimulus which goes up all the way up the sensory system, through the spinal cord, to the brain, and it alerts the body as to where the pain is arising from and what is the first response people would have when they have such an experience. They would, yes, of course, they would pull back. And why is that so? Because pain is a protective reflex. All of us know that pain is there to protect the body from further harm. But is the pain pathway as simple as the way we see it? Okay? Let's break it down into 4 main parts. The transduction, which is the stimulation of the pain receptors. The transmission, which is going up the nervous system, up to the spinal cord. Modulation, which is altering of this impulse in the spinal cord and the brain so that its impact is varied. In some people more, some people less, but that's modulation. And the perception, whereas that part of the brain which perceives and tells you where exactly this painful stimulus is coming from. So mind you, all this works fine in acute pain. Chronic pain is a different ballgame. But this is just for the simplicity of the talk. I would like to break this pathway down into 4 components. If you look at the picture on my left, it tells you that the interaction of the neurons at the spinal cord level, that's a portion of the spinal cord where we see the nerves entering the spinal cord. So we see there's a complex interplay of neurons there, and it's not as simple as we think it is. And that can be described, well, just to explain that, I will give you an example of 2 patients of similar demographics, okay, similar age groups, similar surgeries. Both of them have had abdominal hernia surgeries, but they're having different responses to pain. You walk in, it's the day after the surgery. You walk into the first patient's room, and there he's sitting up, all okay, just going, all happy, waiting to get discharged, and asking you when the bill will be ready, and say, I don't know what the holdup is, just calling up the billing section and say, okay, just let me go home, I'm fine, I'm feeling okay. Walk into the next patient's room, and this is how the patient's going to be. Similar demographics, the age group is the same, background's the same, no change, the surgery is the same, similar. And the analgesic requirement of the second patient is way beyond that of the first. And he's writhing in pain, unable to get up from the bed, his family members around him, consoling him, and he's begging you to make him stay for at least a couple more days till his pain is under control. Why do you think there is a difference? And it's very tempting for us to tell the second patient, why don't we just ask the first patient to walk into your room and show you how pain is supposed to feel like? Do you really, I don't think you should be in so much pain. I think it's all in your head. It's tempting. Of course it's in his head, but it's not in the way you all are imagining it, okay? You run both these patients through what we call a functional MRI, okay? This functional MRI is not just tells you about the structure of the brain, it tells you about the blood circulation to various parts of the brain at any point of time. If you run both these patients through functional MRIs, you'd notice that the areas of the brain that light up for the second patient are many more and wider in comparison to the one that is experiencing less pain. So pain is the pain that the second patient is experiencing is real. Pain is what the patient is telling you it is, and he's experiencing it, and you'll have to take what he says, okay? So why is it different then? So this can be understood by understanding what we call the pain matrix. So these are the areas of the brain that, if you remember the pain pathway that I discussed a few slides earlier, it told you how the impulse goes up and then you have a perception of pain. But it's not just as simple as that. The number of areas of the brain that are involved in a person's experience of pain are not just the sensory cortex. There is input from the anterior cingulate gyrus. There is input from the insular cortex. There is the limbic system which is involved. There is the prefrontal cortex which is involved. And what determines how much of an input comes from these areas? There are so many factors involved, including the person's socio-cultural background, the previous experience that the person has had with pain, the personality of the person, maybe what the conditioning, or a relative who's had a similar experience and had pain. All these set memories, set pathways within the person's brain and give him an experience which is unique to the person who's experiencing the pain. Mind you, it's not that the pain matrix stays the way it is and this person is doomed to be the way he is. It's just that these neural pathways are real, but the brain has neuroplasticity, and these things can change. There are various techniques which are adopted, especially in people who are suffering from chronic pain, and these things can be modified. But what this person experiences is a sum total of his pain matrix. We, as palliative care physicians, are very grateful to Dame Cicely Saunders. I think the people in the UK and all over the world can really vouch for what she did to make the entire world recognize the importance of palliative care. She coined the word total pain. And so she said, she realized very early that the pain that the person is experiencing, especially when it came to a palliative care patient, was not just physical, but had a psychological component, a social component, an emotional and spiritual component. And what do we mean by this? So the pain that a person experiences, especially a palliative care patient, would be something that would be caused by the physical component, would be by maybe the disease itself, or as a result of the treatment that has been given, as a side effect of the treatment, comorbid causes which is going on. But in addition, there's a psychological component which is contributing to this pain matrix. There's an anxiety, there's a fear of suffering, there's depression in the background, there's a fear, there's a past experience of illness which may contribute. Or it may be the social component. The person who's experiencing the pain will be realizing that also what's going on in the person's background is that there is a loss of job, loss of social standing, a financial concern. The fact that the person is going to be a financial burden on the rest of the family, is going to be dependent on the family members, perhaps. And then there's the spiritual component. There's anger in the background, anger with God, anger about why this happened to the person, why I have to find meaning in this, what's happening in my life, and there's a fear of what's going to happen. Okay? So having said that, and having revisited the understanding of pain, now we come to the point in which there's a patient who walks in, it comes right in front of you, and you want to assess how the person is experiencing the pain, and would you want to really assess and be able to treat him or her effectively. And so, first of all, we need to know how we classify the pain that the person is experiencing. Okay, so the various ways pain can be classified. So when the person gives you a history, so 80% of the clues come in the patient's history. And then we also know that there are different pains which would be going on simultaneously. So we need to catch the clues. That this is a phrase I'm going to use a lot more the rest of my presentation. We need to catch the clues. So first of all, we need to know, is this acute, something that happened in less than 3 months, or is it chronic, something which has happened over the past 3 months and beyond. So this is also, again, this temporal characteristics is just for the ease of us to understanding mechanisms which may be happening in the patient. And so it's again a clue, but getting the time frame is important. Next, we need to know whether this pain is arising from the somatic nociception, something which is somatic in nature, the rest on the body, or something which is happening in the viscera. So is it a nociceptive pain arising from the somatic nociception, or is it a visceral pain? And I will come and explain how we recognize these, because recognizing them is slightly, each of them is slightly unique, is unique, sorry. And then we have this category called neuropathic pain. I'm sure most of you have heard of it. Have you all heard of neuropathic pain? Yeah, very. It's good that a lot of people do know it because it's different from nociceptive pain. By definition, anything which causes injury or a lesion of the somatosensory nervous system stimulates neuropathic pain. It could be peripheral or central, but recognizing it is very important. Then when we define and when we talk to the patient a little more, we need to know whether there's something going on in the background. Is the pain there all the time, constantly? Is it there or is it there only during certain times? Do certain things trigger it? Or is it a background pain or is it a breakthrough pain? Now the breakthrough pain is, as the name suggests, is something which causes an acute exacerbation of the pain. And so a person might have a background pain, but certain things could worsen those pain scores. This breakthrough pain could be related to an incident. Like, for example, if a patient has an ulcer in the mouth, chewing and swallowing worsens the pain. So that's an incident which stimulates. Or somebody has, let's say, a metastasis in the bone, putting his foot or her foot down on the ground just causes the pain to go up the roof. So is it a background pain? Is there also instances where there are breakthrough pain? Is there breakthrough pain going on? And is it an unpredictable breakthrough? As in, is it like an intestinal colic which comes up without rhyme or reason? All of a sudden, patient has a severe spasmodic pain in the abdomen. So it could be an unpredictable breakthrough pain. While we probe further, I switched it off. Sorry. What did I do? Okay. While we probe through further, we'll know also we need to know whether this pain is related to the end of dose interval. So if the patient is on analgesics already, whether the increase in the pain is linked to the duration of action of that analgesic and if there is an end of dose interval pain, okay? Just to touch upon what neuropathic pain looks like, it's a burning or shooting, tingling, and altered sensation, most often in a dermatomal distribution. If a patient presents with a raised intracranial pressure, most of us in the medical profession know that there is a headache which worsens on lying down and is there more in the mornings and is associated with nausea. Or if the person is having some bone pain, it may be worse on weight bearing. Any crampy intermittent pain in the abdomen might be an intestinal colic. As a person who presents with the right upper quadrant pain, which with tenderness, it could be that it's a capsular stretch and a liver pain, or pain in a particular muscle could be a spasm of that muscle, there could be trigger points, etc. So asking some questions and getting some clues is the key. We may not understand the pain completely, but at least if we're able to get the history, we could run it along, or maybe a specialist who's able to interpret it, but getting the clues and the onus of getting the clues is on the primary care provider and the person who's with the patient all the time. This person will be able to get better clues than somebody who comes and sees the patient once in a while. So getting the clues is extremely important. Okay, there's another slide with the same things which tell us about the symptoms. Okay, now I come to the next part of my section. When we do see a patient in pain, now having understood the categorization of pain, the revisiting the pain pathway and the pain matrix, We know, what do we do when we see a patient who's come to our care? We need to screen all patients at each contact and have to particularly ask them the leading questions. Are you in pain? If you are in pain, if the person is in pain, find out where the pain is and what is the characteristic of the pain. We need to measure the pain. I'll come to that in a bit, but we need to measure the pain. And then comprehensively evaluate each patient and find out and get the clues and re-evaluate every time the pain pattern changes. These are the 4 things that we need to remember at the end of this talk. I think we should keep these things in our mind, that we need to screen, we need to measure, we need to comprehensively evaluate a little more in detail when the patient does experience, then the patient's history tells you that the person is in pain, and then when the pain pattern changes, you need to re-evaluate, okay? So screening, we all know, we need to have a good assessment, and more than one pain may be around. Each pain has to be assessed separately and look for the clues. Look for red flags. Some conditions like spinal cord compression or raised intracranial pressure or fractures in any part of any long bone, small bone, we need to look for these things because these are emergencies which might need further and immediate medical attention. The spinal cord compression, especially in somebody who's having a metastatic lesions in the vertebral column, we need to understand that the person might present with a sudden weakness of the lower limbs, bowel bladder incontinence, and this can be treated early to prevent further damage, and so this thing needs to be understood and recognized early enough. Raised intracranial pressure, again, there is specific medication which is available to treat it, and fractures, of course, if it needs internal fixation, it does, otherwise external immobilization would be needed. Whenever we get a history, I said 70 to 80% of the clues are in the history. Look for Socrates. His face should pop up. He's a great philosopher, but the mnemonic that goes along with his name, which pain physicians use very frequently, it tells us about the site, the onset, the character, radiation, associated symptoms, since when the pain has been a part of this patient, what are the exacerbating factors, what are the relieving factors, and what is the severity, okay? So Socrates is another thing that you need to take home with this talk. Remember that you need to remember his name, and whenever you assess a patient in pain, these points have to come to your mind. If we do get a call from a hospital, and the person tells you, this person's a diabetic, his sugar's a little bit high, so I gave him a little bit of insulin, and now it's a little bit lower than what it was. Would such a history be a good history for anybody to get an idea about the person's sugar? A little bit high, I gave him a little bit of insulin, and now it's a little better. I think all of you will agree with me that it's not a what should I say, a complete history. It's not accurate at all. We need to know what the value of the sugar was, how much of insulin was given, and what the sugar is after. Why did I bring this up in this talk? It's because I need to emphasize the fact that any pain which the person experiences, and when you're taking a history, you need to measure what the pain score is. This can be done by various means. It could be any scale that the institution or the hospital that you're working in, the clinic follows. It could be an institutional protocol, either the visual analog scale or the numeric pain rating scale or the verbal reporting scale. It doesn't matter. But one standard protocol across the hospital or the clinic that tells us what the pain score has been when the person presented, what implication the pain has had on the functional well-being of the patient. And this is by use of multi-dimensional scales like the brief pain inventory or the Meggle pain questionnaire. Either of these could be used by any institution, but one such scale has to go along with every patient to know how we are headed, what it was in the beginning, after start of treatment, in what direction we are heading, okay? One factor that has to be remembered that not all patients will report pain. Self-reporting is the best way, but not the non-communicating patients will not tell you, obviously will not tell you they're in pain. So what are the clues we look for? We look for grimacing and frowning, groaning, crying, refusing food, refusing care, lying on one side, favoring one side, not moving a limb. So these are the clues that we look for in non-communicating patients. There are scales which are used, the Abbey pain scale and the pain assessment in advanced dementia scale. These can be kept ready, especially the Abbey pain scale is very popular to be used in non-communicating patients to be able to assess whether there has been any change after the start of analgesics, perhaps. The third point that I talked about was comprehensively evaluating the patient. This is whatever I've spoken in the past. You have to define the temporal aspects, define the pain quality, try to determine the etiology if possible, know that there's a concept of total pain, and that's why we need to involve other team members, and a social worker's role cannot be emphasized enough. Okay? Examination of the patient and limiting of investigation has to be done to as much as necessary. Okay? The social worker can assess the cultural, psychosocial, and the financial needs and be able to assess and find out what are the other factors contributing to the person's total pain. And every time there's a pattern change, we have to reevaluate what has been done and what can be done for him in the future, the patient in the future, sorry. The last part of my talk, after we've now assessed where the person's pain, where we have some idea of where it's coming from, we have been able to categorize and tell us, and get the scores ready, we know what has to be, we know where the pain is coming from, we have mapped out, and now we need to manage the person's pain. One has to remember that not all pains require pharmacy. We need to look for clues, reversible causes, and then assess and understand comprehensively. So this Venn diagram that I picked from the Palliative Care Formulary, the 8th edition, which is the latest edition, there, it gives you the multifaceted modes in which we need to treat a person's pain. Okay? The correctable causes have to be identified and treated. If it is a cough or constipation, which could be a side effect of the treatment that the person is having, is a cause for the person's pain, then we need to make sure that we've treated the cough and we've treated the constipation and not just given analgesics for the pain that the person is experiencing. We need to find out where it's coming from and treat the root cause. Sometimes if there's a bone metastasis or a tumor in a tissue which is amenable to radiation or chemotherapy, the person might require might require radiation treatment, might require chemotherapy to shrink the tumor and help with the pain. The non-drug measures which are used, which is the second facet of this, the multimodal analgesia. Sometimes it is positioning, and then sometimes bracing of the particular joint, modification of the environment where there could be occupational therapists involved, helping modify the environment so that there's no exacerbation of the pain. And sometimes therapies like relaxation therapy, acupuncture, mindfulness, there are many things which can be done non-pharmaceutically, which can be used to treat the person's pain. And last, but definitely not the least, are the medications that we prescribe. In order to give people a ready reckoner for medically managing pain and for it to be relevant across the world, the WHO, about 40 years ago, created the WHO analgesic ladder. Does everybody know about this ladder? Yeah, I'm sure a lot of people do, because though it is not complete, it serves its purpose in serving people across the world. So the first rung of the ladder is is to do with mild pain. The second is the persisting or moderate pain, and the third is the severe pain. And this was originally brought about for treatment of cancer pain, though a lot of physicians then extended it towards non-cancer pain, and then, they thought it was a ready reckoner for post-operative pain, and the use of opioids became a lot more rampant than they should have been. But then the pendulum of the use of opioids swings in different directions. So sometimes when they restrict it too much, it's not being used for the people who need it, the ones who deserve it. And when it is not being given, and it's given freely, it's being misused by the people who don't need it. It's been like this across from many years. Now, the WHO analgesic ladder incorporates the use of non-opioid analgesics for the step 1, which are paracetamol, NSAIDs, with or without adjuvants. I'll come to what adjuvants are. And those can be used for mild pain, and if there's no contraindication for the use of NSAIDs. We switch over to step about to moderate pain, where weak opioids are being propagated, especially in places where strong opioids are not used. Strong opioids in low doses can be used in step 2. The weak opioids that they speak about are tramadol and codeine, which are not without side effects, but they can be used wherever strong opioids are not available as freely as they should be. Along with the use of weak opioids, we use non-opioids with or without adjuvants. And in severe pain, strong opioids are the mainstay. The strong opioids which are commonly used, and the prototype is morphine, but fentanyl, buprenorphine, methadone, and oxycodone are the drugs most commonly used, with or without non-opioids and with or without adjuvants. Another rung of the ladder has been added, most often in chronic non-cancer pain, but also in cancer pain, and that's for invasive procedures such as the use of nerve blocks, spinal analgesics, intrathecal analgesics. With these things can be added in to reduce the systemic consumption of analgesics, and an intervention such as nerve blocks can bring down the requirement of analgesics. Another thing that has to be a take-home message from this talk is whenever analgesics are being started for palliative care patients, the principles that are to be used are you give it by the clock, make sure that there's a round-the-clock cover, try to give it in a timely fashion, and then make sure that the cover is complete. Give it by the mouth unless it is reached a time where the person can't take anything orally, and then you have to look at alternative routes. Give it by the ladder. The WHO ladder is a ready reckoner, though it just the principles that you may use when you start treatment and continue, just to escalate or de-escalate as necessary, and by the individual. So the individual has to be taken as a whole. Just look at how frail the person is, how much, and the titration of the medication has to happen by keeping the patient in focus. Okay, so these are the four things and the fifth one is the attention to detail. But the four things: by the clock, by the mouth, by the ladder, and by the individual. One doesn't need to remember medications and dosages by heart. Nobody can remember off the top of their heads. Everybody uses ready reckoners, I can tell you for a fact. And then there are people who've been on certain groups of drugs. You want to change over to another group of drugs. There are opioid conversion charts which are available as a free resource across the internet when you take it from a reliable resource like the Faculty of Pain Medicine in the UK. They have ready reckoners. You have to calculate in order to help calculate how much of oral morphine equivalent the person is taking. You want to switch over from one to the other. So what I'm trying to emphasize is that these things are available as resources. You don't have to remember everything, but the need to start analgesics is something that has to be recognized early. Yeah. So the principles would be you'd have to engage patients and their relatives and engage the patients for them to remember that it may not be achievable to be pain-free all the time. You have to set realistic goals, pain-free overnight perhaps, pain-free at rest, pain-free of movement, try to reassess them in a timely manner to know where your analgesics is going. give patients and their relatives information and instruction, allay fears. What kind of fears do they have? It's very common for patients to think that once you start a strong opioid, either they're going to be addicted to the medication, they worry that higher analgesics mean that the illness is progressing, they believe that pain, some of them believe that pain is an inevitable part of their treatment, of their illness, so they need to go through what they're going through. Some worry that analgesics may make death come quicker. Some worry that they don't have anybody to contact after hours. Reassurance and working towards with the patient is important. Review frequently, and renal and liver functions have to be assessed initially and somewhere along the course of treatment to know whether we are okay with the dosages and to make sure we're on the right path. So just to give an example of the prototype morphine, we usually start with a small dose, like a 5 milligram dose. This is not standard, but it is just as a small example that we can start with a small dose 4th hourly as an immediate release, and then keep a smaller dose if it's a frail patient, and re-evaluate and titrate after 48 hours perhaps, and see how we are going in terms of the pain. If required, increase the dose, and then we'll be able to get a framework. If we want to start a sustained release medication, then we know what the requirement has been, and then we go ahead with the sustained release medication. And the constipation, nausea, vomiting, sedation, respiratory distress. These are the side effects that most commonly happen with opioids. Of course, everybody dreads respiratory depression, and that should not be something that should prevent you from starting strong opioids when needed, with the requisite checks in place, with the requisite measures to make sure that these things are recognized early. We can confidently start the medication. I just wanted to quickly brush through. Transdermal route is another route of giving the medication if the oral route is not available. If patients are on Ryle's tube or on gastrostomy tubes, liquid formulations are available. And lastly, but not the least, is the injectable if you don't have any other ways of giving them the analgesic medication. What are the adjuvants we talked about? Neuropathic pain. So most commonly, we start off with a tricyclic antidepressant like amitriptyline or pregabalin, gabapentin. That's the group of drugs for the treatment of neuropathic pain. If it's a spasmodic abdominal pain, my next speaker is going to speak about bowel obstruction management, but what I want to say is that if it's a treatable cause, we need to see what's causing the pain. If it's something which doesn't need further surgical intervention or another medical consult, then we could treat them with simple antispasmodics like hyoscine, butylbromide, but that's again after an assessment has been done. Steroids have a role for raised intracranial pressure, for edema due to pressure by tumor, for bone pain, for spinal cord compression. Bisphosphonates is another group of drugs which is used for helping calcium deposition in bones and to help with bone pain. Okay? The non-pharmacological measures, TENS, acupuncture, heat and cold therapy, just talking to the patient, getting the psychological factors, helping them cope with what's going on in their mind, helps alleviate pain. And complementary therapy, teaching them mindfulness techniques, meditation, massage. So it's not all pharmacology. We have to keep all these multimodal methods of dealing with pain in mind, okay? And so what is my take-home message? Pain relief is a basic human right. Pain is what the patient says it is. Screen all patients for pain. Look for clues. Not all pain needs drugs. Follow the WHO analgesic ladder and resources are available. So pain relief does improve quality of life. We as a team can make a difference. Thank you. Yeah.
Thank you, Dr. Almeida. That was a very far-ranging discussion about pain. I think if anybody has any particular questions, then they can always email or speak to Dr. Almeida afterwards. Okay, so we're now going to move on to Dr. Angela Halley, who's come all the way from London, Royal Marsden Hospital, to talk to us about malignant bowel obstruction, another very difficult clinical scenario. She's a consultant in palliative medicine at the Royal Marsden and the head of the symptom control and palliative care unit there. She's also an honorary consultant in palliative medicine at the Royal Brompton Hospital. She's the lead for audit and quality improvement, and she's the co-chair of the Trust Clinical Audit Committee and Drug and Therapeutics Committee. She's clinical lead for Learning from Deaths and Trust Mortality Group, and she's the palliative care representative on the Parenteral Nutrition Group, which has developed a pathway for expediting the discharge home of patients at the end of life who are still requiring parenteral nutrition. Dr. Halley is the principal investigator on a number of studies, including an RCT of methylphenidate for fatigue in cancer. She has an interest in developing early integrated palliative care in hematology and patients undergoing CRT treatment. Dr. Halley has an MSc in palliative care from King's College London. So thank you for waiting until the end of the day, Dr. Halley, and welcome to
Gosh, you've all done very well. This is the total graveyard shift, and it's also about a subject which my team will say is the worst patient group they ever look after. So I am going to talk about this quite quickly, but we'll cover quite a lot of ground, and I hope it's not too technical. Also, thank you very much for inviting me to speak today. It's really a wonderful pleasure to be with you all on Cayman Islands. So just let me indulge you in where I've come from so I can show you where I live. So there are two pictures of the two hospitals that I work in. The Royal Marsden in Chelsea is at the top, and the Royal Marsden in Sutton is at the bottom. One's a very old Victorian building, and one's a very ugly 1960s building. Both need repair and regeneration, but are a work in progress. And this is my team. Very grateful to allow them to come today because they're covering the wards back at home. And I thought it was important to share their faces with you all. So I'm going to talk about the pathology of malignant bowel obstruction, how we might go about managing it with drugs and symptom control, and then a bit about parenteral nutrition, which kind of goes hand in hand, I think, with bowel obstruction. But I do just have to warn you that this might be quite UK-centric in its approach, and I hope it translates quite well to the Cayman Islands and the Caribbean in general, but that's what we'll discuss. So what is malignant bowel obstruction? Well, it does what it says on the tin. It's a blockage of the forward flow of gastric and intestinal contents through the GI tract, and it can occur anywhere in the large or small bowel. And because of new, differing, exciting treatments that we give patients, it's pretty common, and I would say that at any one time we have about 5 or 10 patients we're looking after on the wards who've got bowel obstruction. So it's a really common presentation and need to be in hospital generally. Those numbers against incidence, you could put any number, I think, against those, any cancer at the moment. I think it's changing all the time, but classically it's in patients with gynecological malignancies, so ovarian cancer, endometrial cancer, and of course primary colorectal cancer. But we see it in all manner of different advanced cancers because of the spread of their disease into the peritoneum and just the change in the natural history of cancer and how that's changing with the increasing treatments we're giving. And why does it happen? Well, it can happen from a mechanical cause or a functional cause. And mechanically, there's an extrinsic compression that can happen to the bowel itself. There can be a problem in the bowel wall, so intramural or intraluminal, which is inside the bowel tube itself, somewhere along its course, blocking the forward flow. But also any number of things can just make the bowel decide it's not going to work. So you might call this an ileus or a functional bowel obstruction, where the bowel just stops moving and doesn't keep going. So why does it happen? Well, cancer does it. So either cancer around the bowel or in the bowel, adhesions. So lots of our patients will not have clean abdomens. They will have had surgery, they will have had radiotherapy, and they can cause adhesions, so scar tissue that builds up in the abdomen. Constipation itself, so having a full bowel, can cause a mechanical obstruction, so can just affect how much is allowing the bowel to move. We often see patients, and you probably do too, with large volume ascites, which act as this great weight, a great compression on the bowel and not allowing it to move forward. And then functionally, anything we do to patients can make the bowel just give up. So salt imbalance in the blood, sepsis or infection. We give a lot of drugs that want to slow the bowel down. And then cancer itself can drive nerve or muscle infiltration in the bowel and affect its ability to move. So this, I thought, was quite interesting. It's a very old schematic from Carla Ripamonti, who has published a lot on bowel obstruction, but it really sums up the sort of symptoms and the constellation of symptoms that I think we see in these patients. So at the top, this doesn't have a pointer or anything, but at the top you'll see that there's a partial or complete interruption of transit of bowel contents. And what that does is that if you can't move the bowel, it just builds up more contents, increase in the bowel lumen, that distends the bowel. When the bowel distends, it wants to contract, it wants to move, and if it can't move forward, it just causes spasm, colic, so this griping, colicky abdominal pain, which is often what patients might experience. But it can also not cause the bowel to contract. It can just ask the bowel to just be distended, and that cause a continuous kind of distension type abdominal pain. But also, as the bowel contents increase, the gut surface area increases, more fluid pours into the bowel, and you just increase the amount of contents in the bowel that can't go down the bowel, and you feel sick and you vomit large volumes, way more than you think the patient's ever taken in, and you're fighting this battle of all the fluid that's ending up in the bowel, not moving through, and just producing lots of vomiting, which is quite hard to manage. There's a kind of a pro-inflammatory response that happens throughout the bowel as a result of the fact that it's got this disruption of continuous forward flow. So palliative care is all about goals of treatment, what matters to the patient, what should we do to the patient, how much should we do to the patient, and I think it often depends on why is the patient in bowel obstruction, what's the general condition of the patient, what's their stage of disease, how might we go about relieving that obstruction, and then encompassing all of that is symptom management. So imaging. So first question I ask is it appropriate? The patient's at home, quite obviously got clinical signs of bowel obstruction, very frail, doesn't want to go to hospital, you can probably manage it empirically at home. Do you need to do imaging to confirm your suspicions? Not always. But if they end up in my hospital, they will get imaging, no question about it. So traditionally in the old days, everyone would get an abdominal film to kind of prove that there probably was distended loops of bowel. Nowadays, everyone goes straight to CT. So patients will come in with a suspicion of bowel obstruction and get a CT scan on the same day. And why is that important? I think scans, cross-sectional imaging is important to see about the level of obstruction, the extent of disease, the kind of areas in which the bowel is obstructed can determine kind of if there's any other surgical management the patient could have. We also used to do lots of contrast radiography. We don't do so much of that anymore, but occasionally we still do barium or gastrograph in swallows or meals or follow-throughs to kind of see, particularly if there's an upper GI obstruction. And then scoping a patient is a diagnostic procedure, but also therapeutic if you need to stent higher up in the GI tract. So I'm a palliative care doctor. I don't often meet surgeons, but I do have to talk to surgeons, particularly about these patients. And I think it's important that we do discuss these patients because sometimes it's quite important that they do think about having surgery, but also it has to be careful patient selection. We know that if patients go straight to surgery, there's a very high operative mortality and they have quite high post-operative complication rates. And patients will often have a very poor stormy course post-operatively if they've had a high output stoma put in because they've got very multi-level obstruction quite low down in the gut and you need to bring the gut out early. You just swap one problem for another in terms of high output stomas, which are very hard to manage. So the poor prognostic factors are things you would know for kind of all kinds of patients, but that are very old, those who have got lots of ascites, lots of distant disease, previous radiotherapy to the abdomen, previous very recent chemotherapy, and the main thing is about the level of obstruction, and if it's multi-level obstruction, then that's quite challenging to bring the bowel out early. So I think we often have a kind of mini MDT to look at these patients quite early on in their disease course to see if surgery is appropriate, particularly based on what their imaging would show. So this is a Cochrane review, which is a meta-analysis of systematic reviews looking at surgery for the resolution of symptoms in malignant bowel obstruction. And my colleagues in London did this repeat review. So they did an original review in 2000, did a repeat review in 2021, and found no difference. There's very little studies done on patients in bowel obstruction for surgical outcomes, but really there's nothing to guide practice, and essentially we need better quality studies to standardise management, but also experienced surgeons in this group to know what the right thing to do is with these patients. So tubes, nasogastric tubes, Rale's tubes. I used to be very foolish when I was first a registrar in palliative care in a hospice, and a patient came in with a Rale's tube in, and I thought, well, that must be so uncomfortable, I'm going to take that out straight away. Well, that was a mistake, because as soon as I did that, they started vomiting and I couldn't control the vomiting. So I think we've got to be careful that they are a really helpful measure, but they're not the most comfortable things ever, especially with the large volume vomiting. Lots of our patients will need a nasogastric tube. They will reduce and manage that large volume fluid that needs to come out. They can be aspirated, they can be attached to bags. Patients can drink more freely and aspirate through the bag. They can be quite helpful, but they're not comfortable. They can cause nose irritation, they can block, they can come out, they look great, and they can be just uncomfortable in the patient's throat. But sometimes they're a really helpful management tool, especially at the beginning of a course of bowel obstruction. I don't know how many people have seen venting gastrostomies. We do them relatively rarely at home, but essentially it's the same as a NG tube, but you're putting in a more permanent gastrostomy tube into the stomach to try and vent the patient. They're tricky, they come out quite easily. Patients think, oh, that's great, I've got a tube in, I can eat what I like. Well, they can't, and then the tube gets blocked very easily and needs to be replaced. So they're not the most easiest things, but they can be more acceptable than a long-term NG tube. And if you've got experienced clinicians who can place them, they can be quite helpful. There was a retrospective review years ago now looking at patients who had venting gastrostomies, and they did improve their symptoms, but patients were really at the very end of life in this study. The median survival was 17 days post-venting gastrostomy, so they were very, very much towards the end of life, and this was for symptom management. So drugs. Often what we do to try and improve these patients is try and manage their symptoms through medicines. So we want to improve their pain. I've noted I put their reduced vomiting to an acceptable level. We may not ever be able to get rid of vomiting entirely, especially if we don't have a tube down, but what we can do is try and improve that. We'll talk a bit about prokinetics and when and where I use them, antisecretory medicines, managing nausea if it's present, may not be present, but if it's present, thinking about place of care, and thinking about route of administration. Obviously, when the gut's not working, you can't just give medicines by the mouth. You've got to give medicines. We give subcutaneous medicines. We use continuous subcutaneous infusions. We might use rectal preparations, sublingual preparations, transdermal or IV medications. So how do we manage the vomiting? Well, we try and reduce the GI secretions, that continuous feedback loop that goes into the bowel, with anticholinergics and sometimes somatostatin analogues. We also use antiemetics and antisecretory drugs to kind of improve, just general antiemetics and antisecretory drugs to improve the vomiting. Metoclopramide is a bit of a controversial drug in bowel obstruction, I think. I think if a patient is being monitored and we think they don't have a hard, closed bowel obstruction, they've got some movement, particularly if they've got peritoneal disease or serosal disease, then we might choose metoclopramide to try and overcome the bowel obstruction. But if they've got a complete tumour blocking the path, there's no point trying to encourage bowel movement, you're just going to risk perforation. So it depends on what the disease course is, and I would also kind of counsel the patient about looking out for worsening signs of colic or abdominal pain. So the kind of most commonly used antisecretory drug is hyoscine butyl bromide, which Shmita mentioned earlier. It's antispasmodic, it's an antiemetic, it's antisecretory, it's very well tolerated. The butyl bromide version doesn't cross the blood-brain barrier, doesn't make the patient drowsy. It's cheap, often used first line. Often there are contraindications, so urinary retention and glaucoma can be a contraindication, but often it's a drug we'll choose first line. You could use hyoscine hydrobromide, there's no real reason why you wouldn't, except that it will make the patient more drowsy. And you could use glycopronium. Traditionally, we don't in the UK. We use that for secretions at the end of life, but if that's all you had, you could definitely use that. Other antisecretory drugs are things like histamine antagonists, so ranitidine, famotidine, provide an antisecretory effect and are good to use alongside other drugs. PPIs, so omeprazole, pantoprazole, esomeprazole, have a strong dose-dependent antisecretory effect, so they're good to use in patients. And we know that they can reduce gastric secretions. Often the challenge is how do you give it to the patient if they're not in an inpatient or don't have an IV line. You can give them subcut, can give them in a pump, but obviously a lot of our patients will have IV long lines in, but if you don't, that can be challenging. So octreotide is this wonder drug that my colleagues love to use and think it's the best thing since sliced bread. It does everything. It's a synthetic somatostatin analog, decreases splenic portal blood flow, decreases GI secretions and GI motility, and can reduce that hypertensive intraluminal state in bowel obstruction. And definitely it's a drug that everyone is using in studies now for bowel obstruction, and probably that's why it's made its way into the guidelines so prominently. My practice and our practice is that we use it second line after hyoscine butyl bromide, but so I know some places would use it first line. There's long-acting somatostatin analogues, so things like lanreotide, which last longer, so you can give a 2-weekly or 3-weekly injection to get effect. They can be quite effective, they're quite costly, but can be quite effective in some patients. There was a French study in 2012 looking at lanreotide versus placebo in a non-operable bowel obstruction, and there was a better response with lanreotide than placebo. So the MASS guidelines, the Multinational Association for Supportive Care in Cancer, updated their guidelines in 2021. These eminent palliative care clinicians looked at how should we manage these patients medically. They had 1 systematic review and 3 randomized controlled trials, and their decision was that octreotide was effective in reducing GI secretions and colic and nausea and vomiting, and their choice of drug for antiemetic choice was olanzapine or metoclopramide. I think there's a debate about what you choose, but I think that's based on what the studies they've seen have used. NICE is the UK kind of clinical guidelines that we have to use, and their end-of-life care guidance in 2015 said that hyoscine butyl bromide should be our first-line pharmacological management, but then use octreotide quite quickly, which doesn't really work pharmacologically, but I think it's because we're expecting the patient to die quite soon. We can then switch to octreotide if they don't improve within 24 hours. So antiemetics in general in bowel obstruction, we've talked about metoclopramide and prokinetics. You could use any of the neuroleptics, I think, so haloperidol, even mepromazine. You could use an antihistamine. It does slow the gut down, but it's often a reasonable choice if you don't want the side effects of neuroleptics. And you can use a 5-HT3 receptor antagonist like ondansetron, granisetron, if you would wish. Ondansetron and granisetron are used because intestinal distension leads to an increase of this serotonin release, and you activate these serotonin receptors on the vagal primary afferent neurons. There was a study of granisetron in 2009 that patients had better outcomes using granisetron in combination with steroids, PRN haloperidol, and sometimes an opioid for pain. Steroids. Another uncertain treatment plan in bowel obstruction. I think they're a really good adjunct, and we use them very frequently for our patients in bowel obstruction that aren't going to go to surgery, that might be managed conservatively and waiting for either further anti-cancer treatment or not. They have a good antiemetic effect and they reduce edema in the bowel. My colleague again did a systematic review in 1999 and found that there was a trend towards steroids being helpful. The p-value wasn't significant, but there was a trend towards steroids being helpful. Number needed to treat was very high compared to that number needed to treat we heard earlier, so 6 is pretty high. But the expert consensus and what we do in my practice is that we trial a short course of 5 to 10 days of high-dose steroids to try and get benefit. There was a French study looking at methylprednisolone for bowel obstruction and found that there was no dose relationship between dose and efficacy. So you could give huge doses and get the same effect as smaller doses. I know there's wide kind of area of variability between doses, but we would tend to use 16 milligrams of dexamethasone a day to try and get effect, and if it's not improving, reduce it quite quickly. So that's a canter through medical treatment for bowel obstruction, antiemetics, steroids, antisecretory drugs, and obviously pain relief. I wasn't going to dwell on pain relief, but it's all the things that we've heard from Smita earlier, which may be useful in these patients. What's the most challenging thing about these patients is the gut doesn't work, so they can't eat. And if they're well and have a good performance status, that's quite a challenge to know how to manage their nutrition. We heard earlier about ethical dilemmas, and this is one of those, I think, because these patients, giving nutrition for these patients is a medical intervention in our minds in the UK, but the patients might feel it's a basic provision of comfort and care. If you give it and then withdraw it, you're withdrawing treatment, and how do you manage that decision-making? There's something about cost. This is an expensive treatment, and how do you ensure there's availability and access to everybody who would need that? And what are the clinical benefits on survival, quality of life, nutritional markers, and the risks? So in the UK, we have a bit of guidance about how we might kind of distinguish which patients would benefit from parenteral nutrition. This is nutrition given into the vein, to a long intravenous line, so that the patient doesn't need to use their gut at all. So the P1 patients are those with an expected short survival, so less than 12 weeks, but with a good performance status and low inflammatory markers. So they're patients that have got quite advanced disease but are holding their own, and actually giving them no nutrition would feel very challenging to do. P2 patients are those who are having treatment, so your classical patient that's having ongoing chemotherapy or surgery, but they may be metabolically unstable and require more intensive monitoring. And P3 patients are those who have slow-growing tumours directly in the bowel only, and they're going to live a long time, but they've got disease affecting their primary peritoneum or ovarian cancers, and you need to think about managing their nutrition. So what's the survival, and how do we work out what to do with these patients? So depending on masses of factors, but often the studies will show that the mean survival of someone with a new onset malignant bowel obstruction is quite small, so in the region of 3 to 8 months. Depending on lots of factors, it could be a lot less than that, could be a lot more than that. It may even be a matter of weeks. And what the poor prognostic features are patients who are older, who already were malnourished before they had a bowel obstruction, who have advanced disease or a deteriorating performance status. Trying to work out whether to nourish somebody or not is a challenge, because we never know quite how long they're going to live without nourishment. We think that life expectancy in a healthy individual with total nutritional deprivation is around 2 months. That's hunger strikers. You may have heard of people in prison that go on hunger strike. They can live for around 2 months, but they're not your classical cachectic, pro-inflammatory cancer patient. So it's very hard to kind of compare the two. So often our decision making is about, will this patient die from their cancer or from lack of nutrition? Should we give them TPN or not? And it's easy to do in hospital, but in the UK it's much harder to do at home, and patients want to go home. So what do the studies say about survival in malignant bowel obstruction on home PN? So in Italy, they seem to put everyone on home PN because they write lots of studies about it. So Bozzetti has done this study in 2014 and helpfully kind of showed the survival curve on patients with malignant bowel obstruction on home PN. At 3 months, half of them lived, and at 6 months, a quarter of them lived. So they had quite a sharp decline, but still 50% of them lived for 3 months. So how can we try and work this out? Well, performance status is a really helpful indicator, I think, for survival and benefit from home PN. We use Karnofsky performance status. You could use ECOG, WHO. But if patients are generally up and about self-caring, they're probably going to do better over time, stands to reason, and therefore it's probably more beneficial to think about giving them home PN, so home parenteral nutrition. Extent of disease, so if they've got lots of distant disease, again, they're going to do worse over time and have a poorer prognosis overall. And then sometimes we use this thing called Glasgow Prognostic Score, which is a composite measure of CRP and albumin, so the inflammatory nature of the patient. Obviously, that's affected by so many things. Most of our patients have got infections, CRP will be high and albumin will be low. They're often quite a good indicator of how sick the patient is and therefore how long they'll live for. So when you put it all together, if they're doing well, if they're up and about, functionally quite well, caring for themselves, they've got a low CRP and a good going albumin, they're going to do well over time or have a 3-month survival probability of relatively high. So then it's worth thinking about getting them home on PN. But what about quality of life? I think that's what we care about, isn't it? Nutritional markers are important, but also how does it help the patient? We think that patients do feel better generally on having a nutritional supplement through PN, but probably not in the last month of life. That probably deteriorates as much as anything else does, and your quality of life indices on PN are maintained up until about 2 months before death. So it all suggests if you think the patient's going to live for more than 3 months, which is always a million-dollar question, they may benefit from PN in terms of quality of life. That's a challenge we have to face in the UK, of keeping someone in hospital to get them set up on home PN, which can take some time when they really just want to be at home with their family, but they've got no other way of getting nutrition and hydration into them. So we're trying to balance this all the time. What are the risks? This is another thing we talked about earlier in terms of burdens, risks, benefits. So there are complications with having a long line giving food into the vein. It's a very warm environment for bugs to grow. They love growing on a PN line. This was an Israeli study which showed that PN was continued until death in a lot of these patients, but there was some catheter complications, so IV line complications, and some acceptance that the patient was dying and stopped the PN. What can go wrong? So we've all seen patients with long line complications, but they can get infection at the entry site of the line or along the line. They can get thrombosis, thrombophlebitis, breaks in the line, occlusion of the line. And then not to mention all the dietetic concerns. So my dietetic colleagues worry incessantly about glucose homeostasis, hepatobiliary abnormalities, bone disease, micronutrient deficiency, refeeding syndrome, of course. So all of those kind of metabolic complications plus the line complications. Having said that, for some patients it's absolutely the right thing to do, and they need nutritional support and fluid support for a long time. So PN itself in palliative care patients is important. Patients should have it if they've got good functional status or a performance status, generally do better if they've got slower growing tumours without significant distant metastatic disease. Potentially they could be having more treatment or have a response to chemotherapy or immunotherapy and a good prognosis, but we all know prognosticating is very hard. And then involving the multidisciplinary team or interdisciplinary team is very important. So making sure we've got good dietetic support, patient and family understand the involvement of having PN at home, what it means, and the clinical teams, both in the hospital and in the community, are aware of what's going on with the patient. We have very good links with our local PN centre and really have quite detailed MTTs about advanced care planning and what will happen when we stop the PN, and have to counsel the patients and their families quite extensively. Again, there was a Cochrane review looking at home PN for people with inoperable malignant bowel obstruction. You'll see there's no answer. We're very uncertain whether HBN improves survival or quality of life in people with malignant bowel obstruction, as the evidence is low and poor and biased. So that can't help us in decision making really, but it's worth knowing that more studies are required. So we need to think about advanced care planning, thinking about what to do when to stop PN, involving both the hospital team and community teams, what are the benefits, risks and burdens, and think about decision making about stopping PN. So that's the summary of malignant bowel obstruction. You've got to the end, well done. My view is that MBO is often a terminal event. It may not be immediately a terminal event, but it's definitely a crossroads in the patient's pathway and probably dictates a change in their treatment or a change in their prognosis. I think it needs careful symptom management. They often stay a long time in hospital with lots of challenging symptoms, with very high nursing needs, high carer needs. That will affect place of care, affect nutrition and hydration management. It's important that we support families through all of that. So that's everything.
Any questions at all from anyone?
Sorry, I'm Richard Priest. I'm the medical director at Doctors Hospital here. Very interesting, thank you. Maybe my summary is probably inaccurate, but...
Sorry.
Sorry?
No.
Oh. It's fine. Yeah. Can you hear me okay?
Yeah.
Thank you. So if I can summarise correctly, and please do correct me if I'm wrong, mean survival was 3 months. But you also suggested that it takes a while to get people established in hospital.
Yeah.
So have you looked at whether the group that aren't treated for whatever reason end up with more or less time at home with their family? Because I'm kind of part of my takeaway message seems to be you might buy them more time, but it's more time in hospital, not necessarily more time at home. Usually,
and I think that's a feature of the health system rather than the clinical scenario. So if you could get them set up on home PN more quickly, then they could probably benefit at home for longer. But you're right. I think often malignant bowel obstruction heralds quite a short prognosis, and getting people home on PN takes ages. But the patient population I look after are not really ready to accept they're not going to have any nutrition or hydration. And ethically, that feels quite challenging to send them home without any of that. So you often spend quite a long time trying to just make all that decision-making in hospital to then just make a kind of judgment at the end that they really just want to be at home or out of hospital, and you'll do away with it. But I think it's a feature of the setting you're in. I know, I don't know what the situation is here, but in the UK there's very geographical variation on speed at which you can get people home on PN, because it's just tricky how it's set up. So I think if you could turn them around relatively quickly, then it's a worthwhile treatment. But often if you see somebody who looks very, very sick to start off with, you're not going to get them home quick enough. You've got to make a judgment call quite early on that that's not going to be the right thing to do for them. Fluids can be a bit quicker, so we'll get people home on fluids quicker, but nutrition is harder.
Any other questions? Yeah.
What is the role of palliative surgical techniques like palliative ileostomy or colostomy?
Yeah. So I think if you've got a single level of obstruction and you've got enough gut to maintain some integrity in the gut, so I think the surgeons say 120 centimetres or something like that. You need enough gut, so you're not just going to have a pouring out
ileostomy that you've swapped one problem for high output stoma, which you still need nutrition for, you still need fluids for, because you're not managing to retain any of that calorific input or fluids in your body. So if it's a low down obstruction, so certainly in the colon or in the very lower part of the small bowel, then you might be able to get away with it. But you need enough gut retained to be effective. And if you've got multi-level of obstruction, you have to bring the gut out, to bring the stoma out so early, then you just end up patients just pouring fluid out of them all the time. So that's the challenge we face. We talk to the surgeons, they will tell me how much gut's left and whether they can successfully defunction their bowel in that time, but that's often the challenge. Yeah.
The second question you mentioned about nasogastric feeding and also about parenteral nutrition, but what about pig feeding?
Well, the thing is, if you want to feed into the stomach, you've got the same problem in the bowel. So the problem is beyond the stomach. So sort of no point feeding through a tube into the gut because the problem lies beyond the stomach. So you're just going to vomit that out anyway. That's the main problem, is if you're obstructing your bowel at the most important part in the small bowel, it's no point enterally feeding. They've got to be parenterally fed to get any benefit. And that's more challenging than I'd love to be able to enterally feed patients because that's quick, easy, much more manageable. But parenterally feeding patients is more complicated. Yeah.
Any other questions?
Thank you.
Thanks, Dr. Halley. You can see why we asked her to talk about malignant bowel obstruction. It's a really difficult problem, and we always dread it. So thanks for all that information. That'll be very helpful. So finally tonight, we have an old friend, and I don't mean that. I mean a friend who's been for a long time, who has in the past summarized the sort of day's events for us in a very succinct way. Dr. Donna Thompson is a member of the American Board of Internal Medicine. She graduated from Colby College in Waterville in Maine. She received her MD-CM from McGill University College of Medicine in Montreal. Her internal medicine residency was completed both in Canada and at the Maine Medical Center in Maine. She was followed by a clinical fellowship in oncology and then a research fellowship in oncology at the Maine Medical Center. Dr. Thompson's extensive medical background includes positions as Director of the Division of Oncology and Chief of the Department of Medicine at Central Maine Medical Center. She was also the Director of the Cancer Research Program at the Foundation for Blood Research in Lewiston in Maine. Her medical education background is just as extensive. She was an assistant in medicine at Tufts University in Boston, an instructor in the biology of cancer at the University of Southern Maine, and a clinical preceptor and associate professor in the Department of Pharmacology at St. Matthew's University School of Medicine, Grand Cayman, which is how we know her so well. She has been an associate professor in preclinical medicine and director of introduction to clinical medicine, as well as chief of clinical medicine preclinical studies at St. Matthew's. She is currently the assistant dean of clinical science at the University of Medicine and Health Sciences. So thank you for coming back, Donna, and we look forward to hearing your comments.
Well, we are running late, and so I'm going to be particularly succinct, I think was the word Jenny used. So, and I want to give a couple of kind of what I think are some important takeaway points from today. I am really glad that this year we included some really extensive clinical things on 3 very important symptoms: dyspnea, pain, and bowel obstruction. It was really great to hear an update of where we are at on all of these things. I also think it was very important to hear that palliative care has become so much more integrated into medicine. And I'm old enough to remember when there was no such thing of palliative care. Palliative care was putting the patient who was going to die soon off on the counter and spend no time talking about them on rounds. And so palliative care, grew, part of hospice, but has moved away from just a role in hospice, and we've heard a lot about that today in integration. And I think it's particularly excellent that we heard a lot from Dr. Stoltenberger about the global need for palliative care and how that has really lagged behind. And whether you're a healthcare professional or an interested citizen, I think this is an important take-home part, and maybe there's something we can all do in that regard. Couple of points that I want to make as sort of take-home points that I think are particularly interesting. I was very impressed early on today when Dr. Stoltenberg showed that picture of the physician by the child's bed. And that was an old picture. I don't know what year it was painted. But when you think about it, sitting there and being kind and caring was often all you could do. We probably didn't even know the germ theory of disease at that point in time, and nobody really knew much of anything, except maybe thinking back to Hippocratic Oath, first do no harm and be kind. And that should always be there. And medicine in the last 100 years, probably the last 50 years, even more in the last 10 years, has become incredibly technical in its origin. And I think a lot of people have become very obsessed with that. But no matter what your job is, you should still be that physician by the bedside with the sick child. And I think palliative care being reintegrated into medicine is really important. And that's certainly one of the images I'm going to remember from today. And we all like to say things like, well, I don't really care what my surgeon's personality's like as long as he's got good hands, or he's a guy who knows his way around the abdomen. I mean, we've all heard that. And the guy could be really awful, but, you know, it would be nice if he was nice too. We've had some wonderful talks from many people about communication and how important that is. And I think the whole business of people giving informed consent and being involved in their care while they're competent. And I think we've gotten away from the era where patients' family members would come up to the doctor and say, you know, don't tell my dad what's wrong. We want him to enjoy the rest of his life. I think that's pretty much gone by the wayside, and we have tried to be communicative not only with the patient but their whole family, and to persuade the family that yes, you're trying to keep the patient from fear, harm, sadness, but in the end, they need to make decisions and they need to know what to do. I think a pitfall still in giving consent while competent is people who give informed consent devices and everything when they're really quite young and very, very healthy and happy are very likely to say, oh, if almost anything goes wrong with me, let me go. But as time goes by and they get sicker, they are willing to accept less and less quality of life. And I think we've all seen patients like that who still find quality of life where they never thought they would. And if they had seen a picture of with themselves where they were, I remember taking care of a friend, an orthopedic surgeon, who had CA of the GE junction. And when I first talked to him, he's a very macho guy. And at the very beginning, he said, well, I'll take the surgery, but if that doesn't go, I'll... And he literally said, I'm just going to blow my brains out. I'm not putting up with being helpless. Well, guess what? He didn't do well, like many patients don't. But he did take radiation. He did take chemo. He reached the point where he was on palliative care. He had a lot of problems with bowel obstruction, ultimately. And he ended up on a morphine drip at the end of his life, and he was still at home with his wife and children. And I looked at him from a big, strong man when I knew him down to about 90 pounds. And you know what? He still found joy in life. And so, you know, what a person consents to can kind of change. And I think we always need to remember that what a quality of life that someone puts up with is very different for every person. So I think that's kind of an important point, too. What I want to close with is one or two things. I think it's very important that we are very self-aware of the biases and thoughts that we bring to this conversation. We talk a lot about, you know, how the patient feels, how the family feels, what they expect. But we have certain kind of biases and prejudices as well. And a couple of things. One of the things nowadays, we don't think much about the spiritual side of illness. And a lot of people talked about that today, and a lot of people find that very meaningful in their life. And I think we've all had the experience where the patient will say, well, what do you believe, doctor? What do you think? And that can be a toughie because, you know, you're not sure if that's kind of a personal space that you shouldn't go into. I know of one colleague who kind of went too much one way. He was very evangelical, and he often approached patients in initial conversation, shall we pray together? That was, I think most of us thought a bit over the top. But on the other hand, A sharp, I don't discuss that kind of thing with my patient. We have to find our comfort level vis-a-vis their comfort level. And we're all living in much more multicultural societies nowadays, and we're going to see a lot more different approaches by our patients to that. And I think we have to think about how are we going to deal with that aspect of care, because it does come up. Two other things I wanted to say of taking away. Sometimes we have to think about what patients want in some of their palliative care. And I know this is kind of more of an older thing than now, but most hospice, this is almost more hospice than palliative care, have a lot of volunteers, most of whom are very good people, want to help out, want to contribute to the community. But sometimes they don't really think about what the patient wants, but what they think is meaningful care for that patient. And I think we have to all, and we too, those of us who are professionals here need to think about. I have one story which I have to say, not to go on too long. A friend of mine's father had metastatic cancer and was getting quite near the end. And she convinced him to have a hospice care person come in and talk to him and, you know, try to maybe cheer him up a little. And this was a woman who was kind of very into like the folk music scene and, you know, sandals, kind of a bit of a hippie. And she brought her guitar and she sat down and wanted to sing to him. And she sang, you know, a couple verses of Kumbaya and, you know, another couple folk songs. And the guy's sitting there getting more and more angry. He has his Red Sox hat on. But he was polite to her, and she left and calls up his daughter and said, don't you ever send one of those GD people over here again. I was trying to watch the Red Sox, and she came in and sang. So we can't, you know, we have to realize maybe if the guy's got the baseball hat on and the TV on, that maybe a folk song isn't the way to go. So I think we need to think about that. Another bias that we have is we all, especially if we're a professional, we kind of think we know best. We know about these illnesses. We know about these diseases. And sometimes when patients make choices that we don't really like, it's kind of hard to deal with. And so we have to remember that we too have kind of our opinions. I can tell you for myself, this sounds almost like confession time, if there's one thing that made me mad in taking care of patients over the years, is people who refuse chemotherapy, particularly adjuvant therapy, curative for breast cancer, because I didn't want their hair to fall out. And I mean, I guess I'm not super interested in beauty, so it kind of annoyed me. Or people who would say other things of, you know, well, I'm ready to give up now. And they had something very treatable, and you thought, well, why? And I think the best outcome you can hope for in dealing with patients is that you develop communication. We talked a lot today about communication and how important it is. And you can really feel, no matter what the outcome is, when you come to the end of the line especially, that you and the patient agree. That when you're beginning to think, you know, there really is nothing left except comfort care. We're going to treat that pain, that dyspnea, whatever it is. And the patient might even start the conversation, say, you know, I think I'm ready. I don't want to have any more chemo. I don't want any more radiation. And you feel, yeah, we've come to a mutual decision at the same time. And no matter what the issue is, I think that's the best outcome. It's very rare that a patient will want to keep continuing on when there's really no hope. And, you know, you do hear, oh, isn't there something else I can do? I think only once in my life have I ever had a patient say to me, you know, I actually think I might even want to consider one of those stage 1 therapies. And, you know, you said to them, well, you know, probably that stage 1 isn't going to do much for you. It's kind of more like you're volunteering at the end of life to be a bit of a guinea pig and help see how well a drug is. But some people will go to that. But as I said, I think for everybody involved, coming to the conclusion, it's time. And so having said that, I always like to end, and I've done this a few times, because no matter what, whether we're talking curative care, palliative care, hospice care, in the end, if we're involved in any of this kind of thing, at the end of life, we do have to deal with death. And a lot of people have different thoughts about this. And for years and years and years, I've always been taken by 2 poems, which, late as it is, I will take the time to read, because I think they express probably the 2 most diametrically opposed visions of how we approach death. And this is something we can think about, our patients think about, and here they are. The first one is by John Donne, written around 1610. So this has been around a long time. It's called Death Be Not Proud. Death be not proud, though some have called thee mighty and dreadful, for thou art not so. For those whom thou thinkest thou dost overthrow, die not, poor death, not yet canst thou kill me. From rest and sleep, which but thy picture be, much pleasure then from thee, much more flow, and soonest our best men with thee go. Rest of their bones and soul's delivery, thou art slave to fate, chance, kings, and desperate men, and dost with poison, war, and sickness dwell, and poppy or charms can make us sleep as well. And better than stroke, why swellest thou then? One short sleep past, we wake eternally, and death shall be no more, death shall die. The second approach, quite radically different, is written more recently by Dylan Thomas in 1951. Do not go gentle into that dark night. Do not go gentle into that dark night. Old age should burn and rave at close of day. Rage, rage against the dying of the light. Though wise men at their end know dark is right, because their words had forked no lightning, and they do not go gentle into that good night. Good men, the last wave by, crying how bright their frail deeds might have danced in the green bay. Rage, rage against the dying of the light. Wild men who caught and sang the sun in flight and learned too late, they grieved it on its way. Do not go gentle into that good night. Grave men, near death, who see with blinding sight, blind eyes could blaze the meteors and be gay. Rage, rage against the dying of the light. And you, my Father, there on sad height, curse, bless me now with your fierce tears. I pray, do not go gently into that good night. Rage, rage against the dying of the light. Okay.
Hello, everyone. Thank you, Donna, for those 2 poems. They were really great. And thank you all for staying with us throughout this day and this afternoon. On behalf of Jasmine, I would like to extend my deepest gratitude to all of you for attending and participating in this palliative care conference today. Your presence and contribution have made this event truly meaningful and impactful. First, I would love to thank our esteemed speakers. They were all wonderful. I enjoyed every single one of the presentations. Thank you for sharing your invaluable expertise, your insight, and your experiences. Your thoughtful presentations and discussion have enriched our understanding of palliative care and reminded us of the importance of compassion and dignity in our patient care. Special thanks to our sponsors, Baptist Miami Cancer Institute, Health City Cayman Islands, Health Services Authority, Aon, the Wellness Center, and Doctors Hospital. If we didn't have these sponsors, this event wouldn't have been possible, so I really would like to thank them. I would like to thank our team from Jasmine, our admin team. They have worked tirelessly to complete this event, and our volunteers. As you know, Jasmine is a nonprofit organization, and we rely on the good heart of the community and our volunteers, so thank you. To all the healthcare professional, caregivers, and all the advocates present today, thank you for your unwavering commitment to advancing palliative care within the community in the Cayman Islands. Your passion and dedication continue to inspire us all. Lastly, I would like to thank the conference organizers. As I did mention, our admin team did quite a bit to get this event today and have this organized and have everything on point. They did a wonderful job. And I would like to thank you all for staying with us. And for those who are joining us online, please remember to fill out the form in our link. And we do have cocktails now, so you can mingle and enjoy that. Thank you all for staying with us. Thank you.